All right.
He has dodged all my questions about these children that were in his.
All right.
He refuses to answer.
The subcommittee will come to order, and the chair will recognize himself for 5 minutes for an opening statement. Thank you, Mr. Secretary, for being here before us today, and we are here to examine the fiscal year 2025 budget request for the U.S. Department of Health and Human Services. Just last week, the monthly inflation data showed that year-over-year inflation was 3.5% in March. Instead of including policies to help everyday Americans, the HHS budget request doubles down on the tax and spend policies that have cut American paychecks. The budget request totals nearly $1.85 trillion and over $100 billion increase over last year's request. Today, we'll hear the Secretary talk why the budget. We need to ask the Secretary to talk about why the budget doesn't lower health care costs, but it spends trillion in new dollars. This misses the mark. The budget does little to address the cost of care for the average family of four, with employer-sponsored insurance paid almost $24,000 in annual premiums in 2023, which represents a 22% increase in the average annual premium a family paid in 2018. Just because someone has health insurance doesn't mean they can afford health care. Further, the Kaiser Family Foundation changes made by the misnamed Inflation Reduction Act will lead to substantially higher premiums for seniors enrolled in a Medicare Part D drug plan next year. This year, seniors are paying an average of 21% more in Part D premiums, with seniors in the 5 states seeing the highest levels of Part D use projected to pay upwards of 57% more in monthly premiums, and this includes California. Those states are likely to skyrocket even higher in 2025. Evidence suggests that these price controls are also leading to less research and development in critical research areas, undermining patient access to life-saving therapies. Instead of working with House Republicans to find a way to ensure working-class families can access the care they need at a price they can afford, the administration's budget doubles down on more handouts for wealthy by permanently expanding ACA insurance company studies and price controls, which will be paid for by raising taxes. Additionally, this budget requests further previous actions from the administration to impose burdensome and unnecessary oversight over nursing facilities and long-term care providers. While I agree we ought to do as much as possible as we can to protect patient safety, this top-down approach will only place more strain on an already overrun part of our healthcare sector and reduce access to care for vulnerable patients. These new proposals come on top of pending regulations that would establish minimum staffing standards for long-term care facilities, costing Kentucky long-term care facilities $69 million annually just to compete. Regulations like these are being considered despite more than 500 nursing home closures across the country since 2020, as well as the industry significantly experiencing unprecedented workforce shortages. I'm disappointed the budget request has nothing to address the influx of illicit drugs like fentanyl coming across our border at a rapid rate. In fact, the budget only mentions fentanyl once in a footnote, despite Customs and Border Protection seizing nearly 10,000 pounds of deadly fentanyl at our southwest border in the first 6 months of fiscal year 2024. We have policy that have passed out of this very committee that I'm disappointed were not included in this year's budget request, such as the Halt Fentanyl Act and Securing Border for Public Health Act. Both of these bills would give law enforcement, including our brave Border Patrol agents, with tools to crack down on drug traffickers and keep these drugs off our streets. I am glad to see that the $6 million request for Comprehensive Opioid Recovery Centers program, which I led in establishing in 2018. These recovery centers provide wraparound services for individuals seeking help to overcome substance use disorder. This was also included in the Support Act reauthorization, which just passed the House, with a broad bipartisan vote. I look forward to working with the Senate to get Support Act signed into law. In closing, I believe it's time for common sense solutions to solve some of the most serious programs affecting American patients, especially the high cost of health care. I urge the Biden administration to work with Congress to find bipartisan policies that can truly lower the cost of care, eliminate ineffective programming, reduce federal spending, and provide more choices for American patients by incentivizing, not stifling, innovation. Thank you. I will yield back and recognize the ranking member of the subcommittee for 5 minutes for her opening statement.
Thank you, Mr. Chairman, and good afternoon. Welcome back to the subcommittee, Secretary Becerra. Today we're going to discuss, as the chairman said, the president's proposed fiscal year 2025 budget for the Department of Health and Human Services. The proposed budget builds on the administration's many successes that have enhanced quality, affordable health care for the American people by doing the following. Reducing barriers that prevent children enrolled in Medicaid and the CHIP program from maintaining health coverage. Prioritizing scientific and medical innovation at our nation's research institutions, such as the NIH. Sustaining funding for ARPA-H, which ARPA-H has this committee to thank for its creation so that they can continue tackling the deadliest diseases facing our nation. Today, Medicare is, for the first time in the history of our country, negotiating the cost of prescription drugs. Now, there are many politicians that talk about lowering the price of prescription drugs. There's one person that got it done, and that's President Biden. That's a wonderful fact, standing very tall. Beneficiaries are already saving money through free vaccines, and insulin is capped at $35 a month. Medicare beneficiaries' prescription drug costs will be capped at $2,000 starting next year. And the budget lowers costs for millions of Americans by expanding the $2,000 cap on prescription drug costs beyond Medicare to individuals with private insurance coverage. So all seniors will be covered in the country. And I think that that is, this is a great accomplishment for the people of our country. The budget also proposes the Congress make permanent the premium tax credits that are drastically lowering health care costs for Americans. Increased premium tax credits fueled record-breaking enrollment in health coverage under the Affordable Care Act this year. Over 21 million people enrolled in marketplace coverage during the open enrollment period, including 5 million new enrollees nationwide. 80% of enrollees, this is really quite a statistic fact, 80% of enrollees found a plan for less than $10 a month. So, Mr. Chairman, when you say, you know, we want to lower costs, it's right there. And these are not junk plans. These are not junk plans. These are excellent plans with the kind of coverage that people actually need to have. And healthcare involves the whole body. Yet our mental health system, as members of this committee know all too well, remains inadequate. The president's budget will turn the tide by investing, it is a whopping amount of money, but it's what's needed in the country, $20.8 billion in behavioral health initiatives across HHS. Women also deserve access to reproductive health care, which is really under fire, to put it mildly, in the country. The budget provides $300 million, a 36% increase from the previous year for the only federal grant program dedicated to providing access to comprehensive reproductive and preventive health services across our country. Importantly, the budget provides $5.5 billion for the Office of Refugee Settlement Unaccompanied Children program, which is necessary to properly care for the children in ORR's custody and ensure their safety after they've been released. I think that I know that my Republican colleagues have demonstrated significant interest in ORR, and I trust that they agree that we need to work to change some things at ORR. I hope colleagues will join efforts to invest in the health of the American people and ensure the budget meets the pressing needs that remain out there for all of our constituents. So I look forward to hearing more from the Secretary, and I thank you, Mr. Chairman, for holding this hearing today, and with my thanks, I yield back.
Thank you. The gentlelady yields back, and the chair recognizes the chair of the full committee, Chair Rodgers, for 5 minutes.
Thank you, everyone, for being here. I wish I could say that this hearing is an exciting opportunity to learn more about President Biden and Secretary Becerra's vision for how we can work together to improve the lives of the American people by addressing major issues such as the fentanyl crisis, the rising healthcare cost. I wish this budget contained bold new ideas from HHS Secretary on how to lower healthcare costs, or at least prioritize implementation and enforcement of existing initiatives to lower healthcare costs. Instead, what we have before us today is a budget request that proposes more than $1.8 trillion in spending for fiscal year 25, with misplaced priorities throughout. It prioritizes spending $250 billion to large health insurance companies to subsidize insurance premiums rather than innovative proposals to lower the actual cost of health care. It favors the pursuit of far-left priorities over implementation and enforcement of bipartisan health care laws. And it signals to the American people who are struggling under the weight of an overly expensive and complicated health care system that help is not on the way. Secretary Becerra, it's the third time that you've testified on the HHS budget before the Energy and Commerce Committee. And you've already testified before Senate Finance and House Ways and Means committees even this year. If there are any indication, we're going to hear platitudes about lower drug prices, but nothing on what you've done to lower outrageous hospital bills and empower patients with the ability to know the price that they will pay up front. We will hear about what HHS is doing to address climate change, but not what HHS is doing to tackle the fentanyl crisis that's devastating communities and killing hundreds of Americans a day. And we'll hear that you'll get back to us, although unfortunately on countless times on questions of critical importance, we haven't heard back. I hope today you prove me wrong. Secretary Becerra also raised a very disturbing lack of transparency from NIH, a sub-agency under your purview, regarding sexual harassment at the agency and institutes it provides grants to, a very serious issue that this committee has been investigating for almost 3 years. At the direction of your department, Mr. Secretary, the NIH continues to obstruct the committee and cover for individuals found to be who have committed sexual harassment or abuse at NIH-funded institutions, including many convicted of crimes. You need to stop withholding critical information from this committee and stop protecting the sexual abusers. The victims deserve full accountability and justice. I'll close with a somber reminder. Rampant inflation is not behind us. The latest reports show that inflation remains persistently high, and it's compounding, making everyday expenses more and more difficult for American households. Your failure to propose a responsible fiscal policy shows again how the administration cares little about inflation and the impact that it's having on everyday Americans. You're quick to propose more reckless spending without regard for how that fuels increased prices and then refuse to take accountability for the harmful result. I look forward to hearing from you on how you plan to address these concerns, and I hope you prove my predictions wrong. I yield back.
Gentlelady yields back. The chair will now recognize the ranking member of the full committee, Mr. Pallone, for 5 minutes for opening statement.
Thank you. Thank you, Mr. Chairman. I want to thank Secretary Becerra for being with us today to discuss President Biden's fiscal year 2025 budget request. This year, the President's budget highlights the huge strides we made with the American Rescue Plan and the Inflation Reduction Act, and the ways that we can expand those successes even further in order to reach more Americans. The President's budget also demonstrates Democrats' commitment to lowering the cost of health care, expanding access to care, and supporting the most vulnerable members of our communities. The Biden administration is working to implement important provisions of the Inflation Reduction Act that are already delivering for the American people. Medicare is now in the process of negotiating a maximum fair price for the first 10 drugs selected in the drug price negotiation program. These 10 drugs are taken by more than 9 million seniors at a total out-of-pocket cost of $3.4 billion in 2022. And the price negotiation is going to make these drugs more affordable. Seniors who take insulin have already seen their out-of-pocket costs capped at $35 a month. And next year, Part D enrollees will have their annual out-of-pocket costs capped at $2,000, saving beneficiaries hundreds, if not thousands of dollars annually on the high-priced drugs they need to survive and thrive. And I'm pleased that the budget provides a roadmap to continue to build on the successes of the Inflation Reduction Act by increasing the number of drugs Medicare selects for negotiation each year and extending the $2,000 annual out-of-pocket cap for prescription drugs and the $35 monthly cap for insulin to people with private insurance. The budget would also extend the Medicare inflation rebate provisions to the commercial market as well, a critical way to further hold down drug price increases. And a number of these proposals are reflected in legislation I sponsored, the Lowering Drug Costs for American Families Act, that would extend the benefits of the drug price negotiating program to those with commercial insurance as well. We have also built on the Affordable Care Act, and I want to thank the Secretary for that. As a result, a record-breaking 21.4 million Americans have signed up for coverage through the ACA marketplace. The average family is saving $2,400 in premiums a year, thanks to the expanded subsidies that Democrats delivered for the American people. I strongly support the budget proposal of making these expanded subsidies permanent so that American families can continue to have access to more affordable care. And the President's budget also addresses the Medicaid coverage gap, ensuring low-income Americans living in Republican-led states that have no insurance today can finally have access to the coverage they should already be receiving in the Medicaid program. Now, without question, these laws have dramatically improved access to affordable health care, and again, I want to commend Secretary Becerra for the tremendous progress that the department has made. I'm also pleased to see that the budget takes steps to strengthen maternal, reproductive, and child health. The budget will require all states to provide Medicaid coverage to all low-income women for 12 months postpartum. We created the state option in the American Rescue Plan, and then made the option permanent, and now we need to require states to provide and maintain this coverage. We also required states to provide 12 months of continuous coverage to children eligible for Medicaid and the Children's Health Insurance Program, providing them with much-needed stability and their parents with peace of mind. The budget will build on this success by giving states the option to provide continuous coverage to children from birth until they turn 6, and 36 months of continuous coverage from there. So again, Mr. Secretary, I strongly support these proposals. Now, I want to contrast the President's budget, in essentially stark contrast, to the plan put forward by the Republican Study Committee. This extreme Republican plan put forth by the Study Committee proposes to restrict access to reproductive care, including IVF and other fertility treatments. It cuts funding for contraception for low-income and uninsured women and endorses a national abortion ban without exceptions. These Republican proposals are dangerous to women's health. And make no mistake, the ripple effect of the Dobbs decision and these extreme Republican proposals will only increase maternal mortality and morbidity. They're completely out of step with the views of the majority of the American people. So contrary to the Republican agenda, Democrats are committed to expanding access to essential health care rather than restricting it. I will continue to fight to lower health care costs and protect the health and well-being of all Americans. I know that Secretary Becerra is also totally on board with that. He, of course, was a member of this body and our friend, so he knows what needs to be done. So thank you again for being here today. I yield back.
Thank you. The ranking member yields back, and the chair will recognize the secretary for 5 minutes to summarize your opening statement. Thank you.
Chairman Guthrie, Ranking Member Eshoo, Chairwoman McMorris Rodgers, and Ranking Member Pallone, thank you very much for inviting me to testify. To put the President's budget in context, let me remind everyone where we were just 3 years ago. When President Biden took office in January 2021, COVID was ravaging our families and our economy, and thousands of Americans were dying every day. I want to repeat that. Every day, thousands of Americans were dying of COVID. In January 2021, the number of Americans with health insurance was, well, like our jobs and the economy, down and on the canvas. 2021 of January, prescription drug prices were skyrocketing, with patients and their pocketbooks at the mercy of big pharma and big profits. We changed that. Today, 3 years later, nearly 700 million shots of COVID vaccines have gone into the arms of Americans. COVID is still around, but we can now manage it like the flu. Today, more than 300 million Americans, a record number, can go to the doctor or hospital and not go bankrupt because they have their own health insurance. Madam Chair, that's bold. More than 21 million of those Americans count on the Affordable Care Act marketplace for their insurance. Another record. And Madam Chair, that too is bold. Today, while Big Pharma is still big, the President's new prescription drug law has brought down the price of insulin to $35 a month for Americans on Medicare. That's a bold reduction in price. Ask anyone who depends on insulin to live. And as we speak, we are negotiating with drug companies to lower the prices of even more prescription drugs, even as they sue us to stop us. Taking on Big Pharma, that is bold. Saving taxpayers $100 billion in the process, that is bold. The President's budget doubles down on the investments that made the comeback of our jobs, our economy, and our health possible. It doesn't just protect Medicare. His budget strengthens Medicare beyond our lifetime. This budget lays out a vision of a nation that invests in its most vulnerable, fosters innovation, and protects every American's access to the care she needs. Perhaps most importantly, it continues our shift from a health system that treats illness to one that sustains wellness. All told, the FY 2025 budget proposes $130 billion in discretionary and $1.7 trillion in mandatory funding to advance our mission and invest in key priorities. Let me share some of those highlights. The budget provides Medicaid-like coverage to low-income individuals in the outlier states that have not yet expanded Medicaid under the Affordable Care Act. When that happens, another 1.5 million of our fellow Americans will have health insurance coverage and the peace of mind that comes with it. This budget builds on the largest investment in behavioral health in a generation. It bolsters the 988 Suicide and Crisis Lifeline. It gives young people support at home and at school. The President's investments in behavioral health workforce would add 12,000, repeat, 12,000 new psychiatrists, psychologists, clinical social workers, marriage and family therapists, counselors, and peer support specialists at a time when their services are desperately needed. Across HHS, the budget tackles the maternal health crisis by improving access to pre- and postnatal care, supporting emergency care services, and expanding maternal care in rural and underserved communities. We are also making childcare more affordable for working families and more available where families live and work. This budget would provide increased wages for early childhood educators. It would fund more than 750,000 slots for children in Head Start, and it provides universal preschool for our nation's 4 million four-year-old children, and eventually it would include our 3-year-olds as well. Our budget grows and strengthens our cybersecurity initiatives to ensure patient safety and privacy, and to keep our hospitals and providers, especially smaller ones and those in rural communities, running and secure. Finally, this administration has made tremendous strides in preparedness capabilities since the pandemic, and we keep building. This budget invests in countermeasures to combat antimicrobial-resistant drugs, expands our monitoring and supply chains, and integrates 200 data sources across federal, state, and local governments to improve information sharing. We can't reduce the health and well-being of Americans to a line on a budget spreadsheet, I know that, but we can transform the numbers on the balance sheet into real investments and services that sustain health and promote wellness for all Americans. So it is with great pleasure that I'm here to testify on the President's 2025 budget, and I look forward to taking your questions.
Thank you, Mr. Secretary. We'll now move to members' questions. I will say we want to get everybody opportunity to ask questions before votes are called. I think votes are 2.5 hours or so from now. So I'm going to stick to the 5 minutes, and I hate to be rude sometimes, but we're going to have to gavel down at 5 minutes and move forward, sometimes even in good conversation. So having said that, I'll stop talking and recognize myself for 5 minutes to ask questions. So Mr. Secretary, we talked yesterday, and one of the big concerns, and And I'm one that if a bill passes, if I don't oppose, and I oppose, and it passes, and that, boy, I hope that it works better than I thought it would, because there's no joy in going, see, I told you so. But we're seeing in Medicare Part D, in my opening statement, the premiums rise 21%, up to 57% in California, or the places like, it could result in increasing up to 57% in places like California. I know are you concerned about these trends in Medicare Part D premiums?
Mr. Chairman, I'm absolutely concerned about the speculation. None of these insurance companies that are speculating that they're going to increase rates have actually submitted their bids. Until we see their bids, it's hard to see what they're going to do with their pricing. But I would hope one thing, if they're claiming that they're going to have to increase prices on seniors and Americans with disabilities on Medicare, they should let us look behind the curtain and understand why they're increasing prices.
Are y'all doing analysis as well at HHS about what you're hearing is moving forward and why they should move forward that way?
Understand that we can't do an analysis until they give us the information on what they're saying is going to cause them to have to increase prices on seniors and disabled Americans.
Well, let's hope the analysis isn't correct.
We're looking forward to getting it, and I hope they share it with the American people, because the American people want to understand why they would propose to increase prices so much for drugs that are already very expensive.
Well, thanks. So I hope it doesn't happen. So we'll move forward. So on the other big issue, or the biggest issue in healthcare in Kentucky is fentanyl. I think it's across the country. Most families have illicit fentanyl coming across the border. And I noticed in the budget request, it was mentioned in a footnote in the budget. What's your plan to stop illicit fentanyl at the border? Or the administration and the Chinese Select Committee, bipartisan Select Committee, published a report detailing the Chinese Communist Party's involvement in illicit fentanyl. So I'd like to hear what HHS and your role, Secretary, are working on.
Mr. Chairman, I've heard this thing about the footnote. What matters more than a footnote is the money. And the president, as you know, has put down some $44.5 billion to fight fentanyl at the border. And it is doing a great deal to make sure we're fighting drug trafficking, doing everything to address the criminality that might occur that could make fentanyl possible to cross the border. Within HHS's budget, because that's not HHS's budget, but within HHS's budget, there are close to $9 billion that the president dedicates to make sure we're going after opioids and drug overdose. And so we would invest that in things like the state operations
Right,
grant.
we all work together on that on the Support Act. That's important, and that's a big bipartisan bill. But and we need to take care of people when they have a substance use disorder. But preventing it from coming here, we know it's coming from China, coming to Mexico, and coming across the border. We have a bill, I think it's Ms. Lesko, she's not on this committee, has that give you Title 42 authority because it is a pandemic affecting our, and so the question is, I don't think the administration using everything that it can to stop what's flowing across the border. And we would like to enhance even a tool for you to have in Title 42 coming across the border. And so you think administration is doing a good job in the number of people coming across our border illegally?
Mr. Chairman, as you know, the president supported a bipartisan proposal to address border enforcement that would have helped us address fentanyl. That was stopped mostly by members in your party who decided not to let that
Well, the House did pass
to
a
the
bill.
floor.
You know, as you remember, the House passes a bill, the Senate never passed a bill to the House. I said the Senate should pass that bill, and then we should sit down and
Well,
negotiate.
that was the bipartisan proposal. And
Well,
it
that was a
guaranteed to
Senate
have
bipartisan
support.
proposal. I said they should pass the bill, and we should sit down and have a conference committee and negotiate the differences, and that just didn't happen. But even said that, the president has tools that he's not using, and we want to give you tools to use in Title 42. Would you be supportive of moving forward with a bill that includes fentanyl in terms of your authorities for Title 42?
We appreciate any support you all could give us. We take a close look at any proposals that you have and then make sure that we're able to move forward together.
All right, and then I only have 40 seconds, so I want to talk about, you're finalizing a rule, you finalized, your agency in May 2023 rule that would require manufacturers participating in the Medicaid drug rebate program to stack or add up all the rebates. I'm thinking, I'm going to go through the whole question because I think you understand what I'm talking about. Has CMS considered the possible unintended consequences of this proposal?
The what consequence?
Of the stacking, where you stack to get a single low best price by stacking all the rebates? And therefore, it's 30 years of precedent showed it a different way, you're changing it, and the concern about people participating in the marketplace and providing drugs to our
Yeah, and
I'll have to get that answer in writing because I'm going to stick to moving forward. So I'll gavel myself down, and I will recognize the ranking member for 5 minutes to ask questions.
Thank you, Mr. Chairman. Mr. Secretary, I think that you know very well that's an issue that I've spoken to, asking you questions about it for almost a year now. And it's the issue of, the Office of Refugee Resettlement and the children that were referenced in the New York Times articles. In fact, you last testified before this committee in July of 2023 after the New York Times reported on the, I'm not the only one that thinks so, horrendous exploitation of children that were discharged by ORR. I asked you at that time whether the children referenced in the articles were still being employed illegally at dangerous facilities. You said you'd get back to me, so I resubmitted my question for the record. 7 months later, I mean, I know that the department is busy doing things, but 7 months later, I received your response to my questions for the record, and what was so obvious was that that question that I had originally posed was ignored. There was no answer from you on that. I think one of the most alarming aspects of this issue is that ORR employees claimed they faced pressure to expedite the release of children at the expense of their safety. Now, I've got questions about each one of these, but I want to get my comments in first. According to the New York Times, monthly calls to HHS reporting trafficking and abuse of children increased fivefold from less than 50 calls in January of 21 to nearly 250 calls in December of 22. I've requested more recent data in my questions for the record, but I haven't received any answer. Yesterday, I introduced the Transparency for Unaccompanied Children Act to strengthen congressional oversight of ORR by requiring the agency to issue timely, public, and comprehensive reports on the Unaccompanied Children's Program. And we need you to cooperate with us on this because I don't think all is well at that part of your agency. So my first question is, and I'm asking it once again, are the children who were profiled by that article in the New York Times still illegally employed today?
Congresswoman, thank you for the question. And I know that my team has been briefing your team and you on this subject matter. And as I've said on many occasions before, it would be nice for me to tell you a more direct answer about what is happening to the children who are no longer in our care and custody. We don't have jurisdiction over them. If you wish to give us jurisdiction over them, that would be fine.
But Mr. Secretary, with all due respect to you,
authority
wait a
to do
minute,
that investigative work.
it's my time. It's my time. Have you worked with the Labor Department? Did you ever call them to see what's happened to these children?
We have a joint operation.
A joint operation on what? No answer?
Addressing the
On
child
no answer?
exploitation.
I think you have the responsibility. You were a
Congressman,
member of
we
the
answer
Congress.
questions based
You
on the
were a
authorities that
member of
we
the
have.
Congress, and our questions are important. I'd like to know what you've done to change ORR's culture to ensure that the agency always puts the safety of children first. What can you tell us on that?
Certainly, I can tell you that the snapshot that you are speaking to back in the early part of 2021 is not the circumstance you see at ORR today. If you recall, as I've said many, many times before, the previous administration had dismantled the ORR operations.
I don't want to, that's not what my question is. Just answer my question. Have you done anything? Share with us what you have done. I think you purport to have done things to change that culture. These children fell into a horrendous situation. And I know that the Department of Labor has, after they leave you and what you do, But there was so much room for improvement in this. And so, you know what? Why don't you answer my question in the questions for the record? And I'm asking you to commit to working with me on this legislation because this needs to change. I think it's a dark mark on all of us when these failures take place. They're the children. We have to answer to God for them.
Congresswoman,
So I'm
I
asking
disagree
you
with the way you've
I'm
characterized
asking
that.
you to commit to working with us on this, and I yield back.
Thank you. The gentlelady yields back. The chair recognizes the chair for 5 minutes for questions.
Secretary Becerra, let's talk about boldness, proposing a quarter trillion dollars in new ACA spending. My question, do those go to people or insurance companies?
Do those investments go to, well, it translates into a record number of Americans getting insurance.
Does the money, does the quarter trillion dollars go to insurance companies?
The investments make sure that Americans can afford to purchase the insurance they need to get healthcare coverage.
How high of a deductible would you consider affordable for someone making the median income in this country, which is around $70,000? So how high of a deductible is affordable?
Rather than give you a speculative answer, what I can tell you is that 4 out of 5 people who are looking on the website for healthcare.gov are finding a health insurance coverage plan that gives them a real quality coverage for $10 or less a month in premium price.
Do you know the average deductible of a silver plan?
There are many different deductible levels based on the plan and
It's over $5,000. Okay, in your statement, you talk a lot about lowering the drug prices in this country. Your budget includes expansion of the price controls, but fails to include any detail on whatsoever those expansions would if they're actually going to work. We've also been waiting for years for this administration to enforce price transparency requirements for pharmacy benefit managers and insurance that the former administration finalized to unwind the black box created by these middlemen. So Ranking Member Pallone and I applauded CMS when they announced enforcement was coming last September. When can patients expect HHS to enforce, but it still hasn't happened. So when can we expect HHS to enforce the drug price transparency rule?
Congressman, we are currently enforcing that law. We're doing it as best we can. As you know, it has gone through a number of iterations in the courts. We continue to try to implement the letter
Okay,
and spirit of the law.
okay, so we're still waiting. Okay, we're still waiting.
Well, we have to make sure we follow any court rules.
It's only been 3 years. Okay, moving on. Secretary Becerra, rulemaking can also have an impact on the budget and federal spending on mandatory programs such as ACA tax credits, Medicaid, Medicare. CMS has been finalizing a number of regulations just in recent weeks. For the 2025 Obamacare rule, will policies finalized in that rule increase federal payments to insurance companies or decrease?
Will the 2025 rule,
Obamacare rule, so the federal payments to insurance companies, the premium tax credits, is that going to increase or decrease federal payments to insurance companies?
well, the subsidies that Americans now can qualify for to help keep their insurance costs down will help make sure those plans are more affordable for Americans.
So I'm asking about the money that's going to the insurance companies. Is this going to be millions, tens of millions, billions, tens of billions?
The plans are operated and offered by private insurance companies within the Affordable Care Act marketplaces.
How much
when we
federal? Okay, sorry, go ahead.
And so when we provide the subsidies will flow through the insurance companies so that
Okay,
they reduce
thank
the
you.
price for those Americans who get the
Going
coverage.
to the insurance companies, so I guess we don't know how much. For the rule titled Streamlining the Medicaid CHIP and Basic Health Program Application Eligibility Determination Enrollment and Renewal Process, so that's the rule. Does that rule increase or decrease spending by the federal government on Medicaid over the next 5 years?
On Medicare or Medicaid?
Medicaid, yeah, Medicaid.
It makes sure that Medicaid recipients can afford to get the coverage they need and
Does
expand
it increase spending?
An investment to make sure that more Americans qualify for Medicaid is going to be good for those
Okay,
Americans.
the question is how much? Do you know how much more this rule is going to require in spending by the federal government? Or are the state governments just expected to spend because of this rule?
Well, remember, Medicaid is a state and federal matching program, so much will depend on what the states do, but the federal
Okay, I'm
government.
going to run out of time here soon, and I'm still not hearing an answer. I know $45 billion more on spending by the federal government on Medicaid in the next 5 years alone, perhaps more. So I find it shocking in preparing for a budget hearing, making repeated statements about commitment to longevity and success of these programs. You can't even answer if we're going to have to raise taxes or not to pay for these or program reductions. Do you have any process in place where rules that increase spending by the federal government actually get any kind of accountability or responsibility? Because Congress has to pay these bills.
Congresswoman, as you know, and as I know from having served where you are, that we cannot spend money we don't have.
Well, you're passing a lot of rules that are committing a lot of money.
And those rules cannot commit us to spending money we don't have.
More to come. I'm out of time. Yield back.
The chair yields back, and the chair recognizes the ranking member for 5 minutes for questions.
Thank you, Mr. Chairman. Mr. Secretary, I'm going to try to get through two issues, hospital price transparency and Medicaid unwinding. So if I make you, ask you to shorten your answers, it's only because I want to get through both. A major bipartisan goal of this committee is greater transparency in the prices that patients pay for health care. And so you have, you have this final rule, department final rule on implementation of the hospital price transparency. And I'm concerned that some hospitals are using the estimated tool to provide patients with inaccurate and misleading price information, and the price estimator tool can be confusing for consumers, contain disclaimers, often underestimate the prices patients will pay, and offers estimates that are not binding. So on this one, I'm just asking you yes or no, if you would commit to working with us to ensure that consumers are able to access accurate price information.
We continue to work in that direction, so I suspect that means it's a yes.
Okay. So now I want to say that I applaud your department's commitment to increasing price transparency and support efforts to conduct oversight of this final hospital transparency rule, because I do think that it's unacceptable that some hospitals continue to make it difficult for consumers to access price information, and I'm concerned with the lack of compliance by some hospitals. So could you briefly discuss what additional steps the department will take to increase enforcement of this final hospital transparency rule?
Well, we continue to work with hospitals throughout the country. Some are better prepared than others to try to address the transparency requirements. But after a while, if they're not making the progress we believe they should, we're prepared to take enforcement action against them.
And that's important, says, because this went into effect over 3 years ago. So any additional enforcement action, I really would appreciate, and I know the committee would. Now, with regard to the second issue, the impact that the Medicaid unwinding is having on American families, I know you're very concerned about it. Since the end of COVID-19, states have, since the end of the public health emergency, I should say, states have been redetermining eligibility for the historic number of people enrolled in the program, and that unwinding process has revealed the staggering degree to which many states' eligibility and enrollment systems and processes are out of compliance with federal law. And that's resulted in Medicaid beneficiaries being unfairly terminated from the program, as you know. So I wrote to you and Administrator Brooks Eshoo about states' lack of compliance with federal law on March 4th and requested that CMS provide a date certain by which states would be required to make commitments and lay out their plans for coming into compliance with federal law. So my question is, if you would describe what steps you're taking to ensure states come into compliance with longstanding Medicaid and CHIP eligibility determination and renewal requirements, if you will.
Since before the unwinding process began last year because of the elimination of the public health emergency that required states to once again go back to the process of re-enrolling everyone who wanted to stay on Medicaid, because you have to qualify to stay on Medicaid, we've been working with states. In fact, we have provided dozens of flexibilities to states to ensure that as they go through this process of unwind, they don't procedurally remove someone from the Medicaid rolls who actually is eligible to remain on. We continue to do that. Our focus has been principally with children to make children aren't kicked off, and we continue to work with them. We are also proposing a rule for moving forward, because as you just said, we learned a lot about what states have done right and what they've not done right, and we're trying to make sure we close those holes that allow states to drop people inappropriately who do qualify for Medicaid. And in many cases, the states have worked closely with us and cooperated. Unfortunately, some states have not taken up the flexibilities, have not shown that they are interested in moving forward.
Well, let me just ask you, as I said in this letter, that we asked that CMS provide a date certain by which states would be required to make commitments and lay out their plans for coming into compliance. When will states be required to reach agreement on these compliance plans?
Again, we have 50 states, Congressman. You know how this goes. With Medicaid, we have to work closely with them. We're not interested in punishing just to punish. We're interested in making progress. We point out where their Medicaid administration is not working the right way. We point out the federal rules that they live under. And what we do is try to provide them with all the support and assistance they need to be able to move their system along. Many states have not made sufficient investments to really address the populations applying. And so we'll continue to work with them. We hope that we don't have to move towards enforcement, but we will do so if it means that that's the only way to protect people in getting the Medicaid they're entitled to.
Well, I would just ask, Mr. Chairman, if, you know, we would like to see a written response to our letter in the near future, if possible, that basically details what you're saying. Thank you, Mr. Chairman. Yield
Thank you.
back.
The gentleman yields back, and the chair recognizes the Chair Burgess for 5 minutes for questions.
Thank you, Mr. Chairman. Thank you, Secretary, for being here. Good to see you again. Can we just talk a little bit about consolidation in healthcare and specifically provider consolidation? Is this a problem that needs to be addressed?
Is provider consolidation?
Yes.
Any consolidation which isn't for the purpose of efficiency should be a problem.
So do you think that we should even preserve independent practices at all?
Should we preserve? That's something we've had forever. There's no reason why consolidation should mean that there shouldn't be independent practices.
Okay, fair enough, and I'm glad you feel that way. And I personally think the presence of independent physicians is an invaluable counterweight to the rise of consolidation that we see in our healthcare marketplace. So what is this administration doing to help preserve independent practice as an option for physicians and patients?
Congressman, we continue to work within the industry to make sure that no consolidation is occurring for monopolistic purposes. We work with the Department of Justice on that. We try to keep prices competitive. I would probably agree with you if you were to ask me if removing those independent practitioners is going to lead to higher prices, and I would probably tell you it absolutely does.
And may I just add, it's going to lead to worse patient care, and that's really what we should be concerned about. I mean, it's one thing to spend a lot of money. It's another thing to spend a lot of money and not deliver the care that people really need. So let me just ask you this, because we got the physician's fee schedule coming up. It happens to us end of every July, and then I start getting the letters in October. So would you consider modifying the upcoming physician fee schedule so that it does not involve the large budget neutrality adjustment and offers physicians stability in contrast to many decades of disruptive payment rules?
Here I'll say, Congressman Burgess, I think, but I hear a question from Dr. Burgess, and what I would say to you is that's a dance we have to engage with together, because, you know, Congress set the rules, the new budget neutrality rules we have to follow, but more than willing to work with you, because, again, if it doesn't really deal with the reality of what the practitioner on the ground has to face, we all should take a closer look.
Well, here's the problem. We need to ensure that this year's physician fee schedule doesn't continue the cycle of large budget neutrality adjustments that drive conversion factors down for providers. And you think that we can do that?
We are more than willing to work with you, because we know that there are a lot of providers,
Okay, I'll
doctors.
give you the
and
benefit
otherwise.
of the doubt. That's a yes, and we will work with you. So, look, we got a problem with, you know, Affordable Care Act, the CMMI was supposed to save money. It doesn't. Poorly constructed models favoring large health organizations, consistent disruptive payment rules driving consolidation. What we just heard this week about the Change Healthcare problems driving consolidation. It seems intuitively obvious to the casual observer that this administration prefers larger healthcare systems and neglects smaller providers. For example, why hasn't this administration embraced ideas such as site-neutral payment reform to lower costs for the patient and reduce consolidation, something that has been included in presidents' budgets for over a decade?
Congressman, probably a longer conversation, but I'd be more than willing to discuss with you the ways that we have continued to try to sustain the smaller providers, because the smaller providers are typically the ones that are in rural America. They're typically the ones that are in lower income America, and we desperately need to keep them in place. And so we have promulgated a number of policies that support smaller providers. We want to avoid them being gobbled up by the big guys.
Okay, here's a pro tip. Site neutrality can replace budget neutrality. We can afford this. We have the dollars within the system. We can afford to do this. It is just the will to deliver on that. There's a big increase in the budget for this year. We're 3 years now post-COVID, and the budget is even bigger than what it was when you all came in 2021. I appreciate your acknowledgement of the prior administration, Operation Warp Speed, providing you the platform of vaccines that did allow for the disruption of the coronavirus. But ultimately, we've got to put the well-being of America's patients first and foremost. Just one last thought, and I will submit a number of questions for the record. Do we have any idea what is the cost per enrollee in the Affordable Care Act now?
Again, that would depend on the plan that they purchase, what their income level is, what the level of subsidy would be.
But you say that the care is basically costless to Americans, but it's not. Americans are paying this bill, and now they're paying highest interest rates on the money they're having to borrow for what you're giving away. Thank you, Mr. Chairman. I'll yield back.
Thank the chair yields back, and the chair will recognize Mr. Sarbanes for 5 minutes for questions.
Thanks very much, Mr. Chairman. Secretary Becerra, thank you for being here, for your work and the Biden administration's work to protect and expand access to care and to lower costs for Americans, especially as you talked about prescription drug costs for our seniors. I want to discuss how this year's budget request provides some strong investments in a few particular areas, the first being our healthcare workforce. Like many on this dais, I've heard from providers and patients alike, you've certainly been hearing it about the very real challenges our healthcare system is facing as a result of tremendous workforce shortages that span every level of care. This year, I'm proud again to join with Representatives Blunt Rochester and Representative Schrier in urging robust funding for HRSA's National Center for Health Workforce Analysis, which, as you know, provides critical high-quality data about supply and demand issues and oversees 9 research centers that provide technical assistance to regional and local groups. Can you discuss why investing in comprehensive data collection analysis initiatives like this are so vital to understanding the full scope of the workforce challenges we face and ensuring that we make the right policy choices to address them?
Congressman, because we know that too often the workforce goes where the money is, and unfortunately some of the deserts, healthcare deserts that we have that are desperately in need of more workforce won't get them. It might be rural America, it might be low-income America, and what we want to make sure is that we have the data that help us determine where we need to make sure that future healthcare workforce goes.
Thank you, and it's a smart investment. I've long believed that we can encourage individuals to pursue public service or other careers that may be paths less traveled for any number of reasons: lower salaries, what are perceived as less ideal geographic locations, et cetera, through programs that offer loan repayment assistance to those who commit to these positions for a given time. That is why I authored the Public Service Loan Forgiveness Program and helped create the STAR loan program for substance use disorder providers. It's also why I'm such a strong supporter the National Health Service Corps. Can you briefly speak to the investments this year's budget makes in helping relieve the student debt burden for critical primary and behavioral health care providers?
The budget, and thank you very much for your support, Congressman Sarbanes, over the years for this program, has made it possible for us to send thousands of healthcare professionals, doctors, nurses, others, into the field and helping mostly underserved communities. And my son-in-law, who is now a pediatrician, is one of those graduates of the program. He got his 4 years of medical school paid for, and the result is now he owes us 5 years of service in an underserved community, and that's exactly what he's doing. By the way, he applied for that program way before I became secretary, so just so there's no confusion.
So
But
the
it
record
works.
is clear. Yeah.
It works. It really works.
Yeah.
There are some 19,000, I think, slots that we have to put the healthcare workforce out there. These are people who may not have otherwise had an opportunity to graduate and become the future doctors. So it is absolutely a great investment, not just for those people like my son-in-law, but for Americans who end up having a great pediatrician to offer services to their kids.
Yeah, let me punctuate the point you just made. It obviously helps those individuals fulfill their career aspiration, but it's more so what it does for the country, and that's why we support programs like that. It's critical that the pipeline that we're talking about right now be robust, particularly given the mental and behavioral health care crisis we face, especially among our youth. More data every day that supports that unfortunate circumstance. I've also long been an advocate for strong funding for school-based health centers. As you know, we've talked about this before, which meet children where they are at school to deliver care in a trusted setting. This year's budget includes robust investments, I see, in community health centers and their related programs, and increased funding for several youth mental and behavioral health care initiatives. How do you believe these investments can work together to ensure every child has access to treatment and prevention resources, as well as, should they need them, more acute crisis care interventions?
Congressman, as you know, there are a lot of phenomenal community health clinics out there in our communities who would love nothing more than to be able to reach into the schools to provide care directly, but they need some support. We put out about a $25 million grant proposal out there for a number of organizations to apply to help stimulate their interest in making that arrangement with schools. Today, we see far more young kids having access to health care through their schools. We want to continue to build on that. We're working through the Medicaid program to help schools qualify to actually get Medicaid reimbursement dollars directly into the schools, because we think the best place to offer a child who's, especially low-income child, health care is where they are 5 days a week.
It's a no-brainer. Thanks very much. I yield back.
Thank you. Gentleman yields back. Chair recognizes Mr. Latta for 5 minutes for questions.
Thank you, Mr. Chair, and thanks for holding today's hearing. And Mr. Secretary, thanks for being with us today. This administration's forced one-size-fits-all approach allowing Medicare to negotiate drug prices in the Inflation Reduction Act is wrong for patients, wrong for science, and wrong for our most vulnerable. The Orphan Drug Act has been in effect since 1983, and even the IRA included a very limited orphan drug exclusion from negotiations. Unfortunately, CMS has refused to correctly apply the timing provision of the exclusion, leaving uncertainty for companies working to bring rare disease treatments to the market. Yes or no, will you instruct CMS to reconsider its decision relating to timing for negotiations and instead apply the law as intended, preserving the orphan exemption and postponing eligibility for negotiation until the date the first non-orphan indication is granted?
Congressman, it's hard to answer yes or no to a question which you phrase in a way I don't agree. The CMS continues, and all of us at HHS continue to believe in the importance of treatments for rare diseases, and of course the impact that absence of access to those treatments would cause to a lot of patients and families. We're committed to implement the law on drug negotiations as we must under the law, which means we have to comply with all the laws, including laws that relate to the Orphan Drug Act. So we're going to make sure that we respect the Orphan Drug Act, because it's a very important law, as we continue to implement under the law the new drug negotiation law.
It's absolutely important that, that there's no uncertainty out there for these companies, because again, on these orphan drugs, we've got to make sure that they're out there, especially for those most vulnerable who need them. Let me follow up. According to reports, in the last decade, 85% of new medicines entered the American market. What this means is that American patients had access to medicines first. Germany had only 61% introduced locally. Meanwhile, countries like Canada, Spain, Austria, and South Korea fell further behind with less than half of the new medicines available. Briefly, given those data points, are you willing to risk the U.S. patients' access to innovative and cutting-edge medicines if the current price control scheme is implemented and expanded?
Congressman, as I believe you know, that the current drug price negotiation law does not include drugs that just barely came on the market. A drug, for it to be negotiated by Medicare, must have been on the market for many, many years. And so those new innovations that you're speaking to would not be subject to negotiation.
Let me just go on, because again, when we're stifling healthcare innovations, often reduce access to new medicines and longer treatment wait times exceeding sometimes in over 500 days. Foreign governments who impose similar price controls cause patients with severe conditions to wait over 16 months for treatment. Has HHS considered how the Biden administration's price controls will impact the wait times for new medicines, treatments, and cures? And let me give you an example. During the work period, the last couple of weeks, I was at 4 hospitals in my district on that period. And I was bringing this up, and one of the nurses, this is in a cancer, where they were giving for infusions at this facility, at this hospital, and she said I'm very concerned about making sure that the patients get these new innovations out there, because she said that she was a Canadian, that's an American citizen now, but one of her very good friends is Canadian, who had to come to the United States to get that life-saving drug that wasn't being offered in Canada. And, it's with these new medications, and, again, as I mentioned, has HHS considered how these price controls will impact the wait times for new medicines, because when these medicines are so, again, I think about everything in Ohio. I think about all the great hospitals we have, all the people come from around the world to come to the United States, and all of a sudden, if they say they can't get these medications, what's going to happen out there to these people?
Congressman, I know that my friend, the health minister in Canada, would probably want to challenge what you just said.
They can challenge me on it, because again, I know that when we were talking about and had hearings, having the information out here,
the health minister would want to challenge you in the way you represented what
that
Canada
they
does.
had to open up in the United States, different states, to make sure that their patients could be treated, because they couldn't get the treatment in Canada, and so they were coming to the United States, to our northern states.
All right, so we can compare notes, but I guarantee you there are a lot more Americans that are going to
I'd be
Canada
happy to
to buy
debate
their
that all
prescription
day,
drugs
because I
than
know
Canadians
that what
coming to the
we
U.S.
saw, because then the Canadians had to shut it off because their citizens were coming here, and Mr. Chairman, my time's expired.
The gentleman yields back. The chair recognizes Mr. Cardenas for 5 minutes for questions.
Thank you very much, Mr. Chairman, and also Ranking Member Eshoo for holding this important hearing, and appreciate the Secretary being with us today. Secretary Becerra, it's great to see you, and many of us appreciate your leadership for taking the time to discuss the essential programs you oversee at HHS. I'm encouraged by the inclusion of crucial funding for responding to the mental health crisis facing our country. As you know, we are nearing the 2-year anniversary of the launch of the 3-digit 988 suicide hotline, which has revolutionized the way we respond to our neighbors in mental health crisis moments. This key starting point for strengthening our response to individuals struggling with their mental health is providing crucial and timely resources across our great country. I commend the proposed budget's focus on an expanded awareness campaign, increased technical assistance support and infrastructure, and continued investment in specialized services for LGBTQI+ youth, Spanish speakers, and the deaf and hard of hearing, and everyone in our great country. Secretary Becerra, as we look to build on the success of 988 and in light of the growing need for mental health services, could you speak to the importance of expanding the mental health crisis care continuum?
Congressman, first, to all your years of dedication to this subject, thank you very much for helping elevate the importance of mental health services. 988, because it has launched so successfully, and within the first, year and a half, some 8.5 million people reached out using 988. It shows that people want help and are willing to reach out. And what we want is to make sure that 988 becomes not just national in scope, but you actually get access to the care that you need. So the next step, to your point, is making sure that that next step of care is provided. That's where these investments that you've all helped make on certified community behavioral health centers, which are 24/7 critical care centers, become indispensable. So we're going to continue to do it. So long as you give us the resources to incent the states to do it, Americans need it.
Thank you very much, Mr. Secretary, and I'd like to remind the general public that we're talking about a country of in excess of 330 million people. And there's probably not a family in America that hasn't been affected by mental health within their own home or within their own loved ones. So it's really important that we get it right. I see 988 as the next 911. 911 was created actually in our lifetime. But today, thank God that Americans across the country, when there's a heart attack or there's some kind of episode like that, they can get that physical help that they need. But mental health is something that I think is new to how we're going to do it, and I think we're doing it better than ever. Before 988, it was hodgepodge of 800 numbers, who knows, located in different corners of the country, and now people can actually access that help locally when they pick up that phone and they call. So thank you so much for your leadership and applying those hundreds of millions of dollars that we, the Congress, have appropriated to do so. I also want to discuss a related issue of increasing urgency, and that is the epidemic of mental illness in children and teens and the strain this is putting on care capacity in children's hospitals. Surges in caseloads and workforce shortages have made it clear that we need to invest in our healthcare infrastructure, particularly when it comes to our children. What can Congress do to support access to pediatric health resources, not just in terms of beds, but also workforce dedicated to youth and our children's population?
We are working, Congressman, with states to try to expand the workforce in behavioral health fields, and also when it comes to child services. We're trying, for example, to promote more residency slots, so the future doctors going into behavioral health services, especially within pediatrics. We'd like to make sure that primary care physicians, the family doctors, actually receive during medical school and their residency programs training on behavioral health services. So when they become family practitioners, unlike today where most of these family practitioners receive almost zero training on behavioral health, that they actually will be able to be a frontline caregiver. And of course, if someone needs more specialized care, they can refer them. But wouldn't have to always refer, because you know when you refer, that's weeks or months of further wait time before your child gets to see a physician they need.
Thank you. How can Congress work with HHS and other appropriate agencies to ensure that services are provided to all children, including vulnerable communities?
Most importantly, we can make sure that the Medicaid program is servicing all kids who need the care where their families can't afford to buy their own private insurance. And if we do that, we're going to probably capture most kids, because about half of all children in America receive their health care through Medicaid.
Okay, thank you very much, Mr. Secretary, and my time having expired, I yield back, Mr.
Gentleman yields back. Chair recognizes Mr. Griffin for 5 minutes for questions.
Thank you very much. Let me start off by saying that when we had one of these broad budget hearings previously, the issue of the Office of Refugee Resettlement came up. I asked you if you would come and talk to the Oversight Subcommittee about it. I want to commend you and thank you for keeping your word, and we had a hearing on it. I do share a lot of the frustrations that you heard from Ranking Member Eshoo earlier in regard to what we're doing, because I do think that, and as I've said many times, we may not agree how they got here, but when we have an unaccompanied minor come into this country, it is our responsibility to take care of them. And I agree with Ms. Eshoo that the failure to do so, doesn't matter why or how, is a stain on us as the committee that has jurisdiction over it, and a stain on the United States.
May I comment on that?
Yes,
very
you may.
briefly? Mr. Chair, thank you very much. First, I agree with everything you've just said. But remember, my jurisdiction, my authorities end the moment I release that child into the hands of a sponsor. So trying to figure out what some employer or company is doing to them, I don't have sight on that, and you don't give me money to have sight over that.
Well, and I do have a solution. I look forward to working with Ms. Eshoo on her trying to solve this problem. I have a simple little bill, 7854, that just says that when you place them, can be before they get there, if that's when your jurisdiction ends, with a sponsor, that you all have to notify the local school division and the child welfare agency in the region, which in Virginia would be the Department of Social Services. Now, I think it's a simple little bill. I look forward to working with you. If there's something we can tweak to make y'all happier with it, I just want to see these kids taken care of. Not directly related, but somewhat related. I happen to be speaking to my favorite juvenile and domestic relations district judge. That would be my wife. And I said, are there some questions? Because they have jurisdiction over a lot of these issues at HHS. And she brought up something, and I actually had a case similar to this many years ago that was not an unaccompanied minor, but a minor. And I don't expect you to be able to give me an answer, but I'm looking for guidance. So ask your agencies to help give me guidance on this. And that would be, and the judges are having a hard time with it. If a 15-year-old comes in front of a juvenile judge with a minor charge, or it could be more significant, but it could be as simple as a traffic violation, if they do not have a legal guardian, and the sponsor without a court order doesn't count, at least not in Virginia. It's the only place I'm licensed to practice or was licensed. I'm currently in mothballs, so to speak. But the judge doesn't have jurisdiction to try the case. The only thing they can do is put the minor, whether they're from another country or from the United States, into the care of the Department of Social Services. Now, as you know, finding foster parents, particularly for a teenager, is very difficult. So the Department of Social Services, in many cases, only has the option of placing them into detention, which, they've gotten a traffic violation in some cases. Some are more serious. Detention is not likely to be the first response of the juvenile court system, except we don't have any place to house them. We don't have any place to put them, and we don't have a process in which to deal with the underlying criminal charge. So I'm looking for some guidance. And if the judge, and so that you understand, my wife indicates to me that in her courtroom, there are 5 judges in her area, Roanoke Valley of Virginia. It happens about twice a month. That's a lot of kids. So I'm just looking for guidance. I don't need a specific answer today, nor would I expect you to have one today. But can you work with me to see if we can't get some guidance to our judges and our local departments of social services? Because whether they're, as I said, whether previously an unaccompanied minor or whether they're just somebody whose parents have flaked out on them, we need to do something for them. Would you agree?
I'm with you, and we'll follow up with you.
All right. During an oversight subcommittee that I chaired yesterday, and some ideas were coming up about how we combat improper payments to Medicaid and Medicare. One of the concepts that came up was having the state auditors do more, and of course, revenues would be necessary to do that. One of the concepts that came up as a part of the hearing, because we were trying to solve problems, not beat each other up, was perhaps on the money that the state auditors find that was going to be wasted, abused, or even direct fraud, that we give a percentage of that money to the state auditor to defray their costs in doing the audits. It's a thought. I pass it on to you. It came up yesterday. Sometimes Congress and the administration, no matter what party is going on, may be able to find solutions. I'd like to work with you on that as well. Would you agree to do that?
Congressman, I think if any state attorney generals are listening to this, they are going to give you a kiss, because when I was an attorney general, one of the things that we wanted is to have the resources to work with the federal inspector generals to do more of this fraud detection and work. And so I think anything we could do to get those inspector generals, the attorney generals to get out there, it's going to bring us money. It's proven. You do fraud control, every dollar you spend on that with those inspectors brings you back about $4 or $5.
And we can spend it on other things. My time's up. I yield back. Thank you, Mr. Chairman.
Gentleman yields
Thank you,
back.
Mr.
Chair
Secretary.
recognizes Dr. Ruiz for 5 minutes for questions.
Thank you, Mr. Chairman. Thank you, Secretary Becerra, for being with us here today. In January, I joined many of my colleagues in sending a letter urging the Department of Health and Human Services to improve healthcare services for senior adults in Puerto Rico by thoroughly reviewing and refining the current formula used to determine payments for Medicare Advantage, or MA, of course, plans in the territory. As you know, Medicare Advantage program base rates in Puerto Rico are well below the rest of the United States and are even lower than nearby U.S. Virgin Islands, which have the second lowest rates. Increasing Medicare Advantage base rates for Puerto Rico to at least the level of the second lowest rate, the U.S. Virgin Islands, was proposed in the Biden-Harris administration's plan for Puerto Rico. Which is why I was surprised that there was no fix or adjustments for Puerto Rico beneficiaries in the April 1st final MA rates announcements for 2025. Can you elaborate on your reasoning for leaving the MA rate for Puerto Rico unchanged?
Congressman, thank you, and thanks for expressing the interest in trying to support the people on the island of Puerto Rico. As you know, Congress treats Puerto Rico differently when it comes to Medicaid and Medicare than it treats the states. And it actually treats the other territories, as you mentioned, Virgin Island as well, differently. We try to follow the guidance that we get from Congress when it comes to Medicare, Medicaid. So on Medicare, the rates that we pay on Medicare Advantage follow the process that Congress gave us in determining the rates. Every year, though, because Puerto Rico, as you mentioned, has lower payments, we continue to try to elevate the payments to Puerto Rico as much as we can. Every year, at least during this administration, the rates that are being paid to the insurance companies have gone up. Now, what's interesting, and this is what I hope you'll help us explore, is why is it that while we continue to pay more to the plans, the insurance companies, to provide those services, have we not seen a commensurate increase in the amount that those plans dedicate to the core services in Medicare? And what happens is that gap is that the money, what we think is happening, we're trying to get answers from the insurance companies, is it looks like those plans are using the money, much of the money we give them, to offer supplemental benefits, which are great. Some of them are like dental benefits. Others are like dog walking services. At the expense of doctors, we think the core services under Medicare should be the first and foremost priority.
So what can we do? What are your next steps to addressing this health equity issue? Puerto Rico is a huge outlier at the bottom compared to the rates of programs in other jurisdictions. All we were asking was from 0.5 to 0.7. So, what can we do to help the people of Puerto Rico? Because there's a brain drain, there's a lack of services, and 80% of seniors use Medicare Advantage. So what can we do to make it better?
So the most important thing that you could do is help us get clear answers from the insurance companies on how they're treating their Medicare program that they offer to seniors in Puerto Rico.
So
But
will
the
you
other
work
thing,
with me
Congress,
on
if
that?
I could just mention,
Yep.
but the other thing we have to understand is, if you ask me to go to a different rate of payment for MA plans in Puerto Rico, then every other state is going to say to me, well, can you change my rate too? Since you changed Puerto Rico's, can't you bump mine up as well?
Yeah, I think there's a difference.
I guarantee you they will.
When you're at the very bottom of the rate at 0.5, and you're seeing the health effects of that compared to other states. But
If you don't have a standard way the way you determine rates, what's going to happen is everyone's going to say, go speak to the department and let's see if you can get the higher rate that your neighbor state has. And we have to have a standard process.
So why don't we work together to develop that standard process?
Let's do so. But help us get those plans to answer our questions.
Will you work with me to do that?
Absolutely.
Okay, so look, I don't have much time. The No Surprises Act, the intent of the law is not being followed. We had these numerous conversations. The courts have had HHS go back to the drawing board numerous times. We're starting to see a lot of gaming in the system with insurance companies delaying their payments, and delayed payments to providers hurts their ability to keep their doors open. So how can we hold them accountable? What can we do to ensure that this system continues smoothly?
So as you know, we have a regulation that requires that the losing party in that in that arbitration must pay within 30 days.
They're not.
Yeah, and so now what we have to do, and with your help, I hope, because remember, our funding runs out this year, we're gonna need money, because if we now have to go enforce against those that are not paying after they've lost, we need some wins so we can actually go out and enforce. So I look forward to working with you on that.
I'd like to know how much you need so we can make it happen.
We'll be in touch.
Thank you.
Thank you. Gentleman's time has expired. The chair recognizes Mr. Bilirakis for 5 minutes for questions.
Thank you. Thank you, Mr. Chairman. Thank you, Mr. Secretary, for being here. As you know, I've been a long, strong advocate of research funding and federal efforts to advance diagnostics and treatment for individuals with neurological conditions, including Alzheimer's and Parkinson's diseases. We are making a significant amount of progress in Alzheimer's, and going through the HHS fiscal year 25 budget in brief document, I was glad to see some of the proposed initiatives. However, I'm disappointed that Parkinson's disease is not mentioned once. For reference, the term equity is listed 77 times in the document, but not one single mention of Parkinson's disease initiatives. As the fastest-growing neurological conditions, what is your agency currently doing to address this rising public health need?
Congressman, thank you for the question, and I assure you that, like Alzheimer's, Parkinson's, and so many other of these devastating diseases are a focus at NIH and many of our programs within CMS. The difficulty, of course, is that we have to follow, it's very similar to the answer I gave to Congressman Ruiz. We have standards that we have to follow based on the laws that you have passed. And so for us to, for example, provide more research money or to include a particular therapy or treatment or drug as part of the Medicare program, we have to follow the process and make sure that we check the boxes, because otherwise, you probably saw an article that came out about a week ago of a number of drugs that the FDA approved, said they were safe and effective, but people took them, nothing happened. And so all of a sudden now all those drugs are not working. And so what we have to make sure is that when we say we're going to help, there's really going to be help coming.
You said that nothing happened. Elaborate on that.
So many of the people who reportedly took some of these drugs, and I could try to make sure I get you that article, many of the people who were taking these drugs found that there was no improvement in their health as a result of taking those drugs.
What diseases are we talking about? Neurological diseases or?
I don't think they were neurological.
Okay, please give me that information.
I will send that to you.
Follow-up.
It just came out about a week ago.
Okay, thank you. It's been 1,144 days since this administration took away seniors' ability to access innovative medical devices. When the Medicare Coverage for Innovative Technologies Rule, MCIT, was repealed, this administration promised patients it would quickly work on an alternative proposal. Every year we ask that question. This year, my colleagues, again, we want to know, what is taking so long, and will you commit to finalizing this new rule by the end of next month, possibly? You know, seniors are waiting on this. They can't wait any longer. Can you address that, please?
Congressman, rather than try to commit to something like within the next month that I can't guarantee that, how about we do this? Let me follow up with you and tell you what the latest is. We can then share that publicly if you'd like. But I'd rather not try to commit to something that I can't guarantee, but I understand the importance of this.
Yeah, it's very important to our constituents. I'm concerned that the administration is forging ahead on a proposed rule that regulates laboratory-developed tests. And, you know, this is a bipartisan issue.
And academic institutions.
Yeah. We recently held a hearing with stakeholders talking about the rule, where there's unanimous agreement on this, that the rule is misguided. Is your department listening to the patients and provider communities here? Expand on, and answer that question if you can. And will you commit to ensuring that patients won't lose access to these types of tests under a FDA regulatory regime? Can you respond to that, please?
Sure. First, I think everyone recognizes that having good testing practices is critical for Americans to know what's going on, whether it's COVID or whatever else. Secondly, we like to make sure that those are standardized so that one test will work because everyone uses it and it works, and we don't have issues that some tests aren't working, other tests are. We want to make sure that that's a standard process. There should not be exceptions unless they're absolutely necessary. Academic institutions are saying that they should be outside of the scope of that. We're saying there's no reason why, in the process of making sure all tests work well, that we should allow academic institutions to be treated better or differently. And so I would challenge your statement that there is unanimity in agreement that this rule is a bad one. I believe the rule is a result of talking to all stakeholders and trying to make sure that we have a process that fits for everyone. No one is special in this process as a laboratory. You have the same obligations to make sure what you produce works for the American people. We want to make sure whoever you are, and we elevate those academic institutions. I went to a really great one, Stanford University. But that doesn't mean Stanford University is so special that it doesn't have to follow the same rules that other laboratories have to follow.
I know my time has expired. Thank you. Appreciate it.
Thank you. The gentleman yields back, and the chair recognizes Ms. Kelly for 5 minutes for questions.
Thank you, Chair Guthrie and Ranking Member Eshoo and Secretary Becerra. Good to see you. As you know, I'm a strong supporter of FDA's efforts to prohibit menthol cigarettes and have led numerous letters signed by the majority of CBC colleagues to the administration in support of the rule, and I truly appreciate the leadership of HHS and FDA in sending the menthol rule to the White House for final review. Any idea that you can share of timeline? I know it's been a kind of slow walked. Any ideas, and will you commit to still being on the right side of this rule?
I have to begin first, Congresswoman, by saying we owe you for the work that you've done to try to help get this across the finish line. I think you do it because you know what it means. It means a lot of lives saved, especially in the Black community, because menthol cigarettes impact the lives of more people in the Black community than anywhere else. And so for that, we are indebted to you. And I hope you do, those jets, I hope, still have a lot of fuel in them. I can't give you a particular timeline. It is in the process. You know, when we see the white smoke, we can cheer if we get to see it, but please just don't stop. You continue to do the work you're doing.
I will not stop. Quickly, my grandparents owned a mom and pop grocery store in New York, and now when I think back how many people was in Harlem asked for Cools or Salem or Newports.
That was intentional on the part of the industry.
I know. I also want to commend the administration for its commitment to safeguarding and enhancing access to comprehensive range of reproductive health services nationwide. The allocation of $376 million to address disparities in maternal mortality and morbidity is a crucial investment in saving the lives of Black and indigenous moms and birthing parents who are so unduly burdened with negative birth outcomes. But what concerns me, I hear from so many providers and groups, especially those in minority populations or those in rural areas, that they are unable to access the funding streams from the administration. A notable illustration of this issue is evident in last year's KFF report, which revealed that no Black rural areas have received any rural maternity and obstetrics management strategies funding until concerns were raised by me and others. So how will the administration work to ensure that funding, reaches the areas that really, really need it most at the end of the day, and not just the bigger organizations, but really the community organizations also?
And Congresswoman, I was recently in both Mississippi and Alabama, and we spoke, and I met with a group of healthcare leaders, mostly from the Black community, about this, but on a number of issues, but this obviously came up as well. What I can tell you is that we're trying to reach all those communities, because the purpose of, in fact, the president's budget calls for more than $370 million to address this maternal mortality and morbidity issue. We wanted to reach the right communities. So if there's something that we're not doing that you think we should, please let us know. We are reaching out. As I said, I traveled to states where this is a big issue. We're going to do everything we can, but we could use some help.
Okay. And I just, we are putting on a Black Maternal Health Forum right now, and I just left Congresswoman Sewell. So I think, meeting with us, would help. And she just talked about it in her area, but thank you. My last question, CMS has proposed a rule that will make sweeping changes to how Medicaid drug rebates will be calculated. Several provider and patient groups have reached out expressing concern regarding the potential unintended consequences this rule could have on patient care and access. Given that this proposal is still under consideration, would your office be willing to follow up with me regarding the concerns?
Absolutely, we'll follow up with you, and I can guarantee you we're not going to do something that's going to impact patient care.
Appreciate that. Thank you so much, and keep up the great work. Thank you.
Gentlelady yields back. Chair recognizes Dr. Bucshon for 5 minutes for questions.
Good to see you, Secretary Becerra. On maternal mortality, I would suggest visiting Parkland Hospital in Dallas and reviewing their program. They testified in front of our committee. They have outstanding results, and their patient mix is uninsured, minority populations. Their results on this issue are outstanding. You might talk to them.
We'll follow up with you on that.
Yeah. There are many issues I would like to cover, including HRSA's effort to modernize the organ procurement and transplant network after my legislation 2544 was signed into law, and I've had that discussion with HRSA. Honestly, the lack of work being done on smoking cessation and cigarette alternatives at the FDA, we need to do more and be more aggressive there. And as was mentioned earlier, in my view, the misguided nature of the FDA's proposed rule on laboratory-developed tests, classifying them as medical devices. We need a law similar to the Valid Act, introduced by Diana DeGette and myself instead, in my view. We'd like for the agency to continue supporting Kidney X. I'm co-chair of the House Kidney Caucus. Innovation in kidney care is still critically important. But instead, I'm going to talk about surprise billing today. But all those issues, I think I'm going to submit some questions for the record. We want to revisit that topic. I believe that the bill was in a good place when it went to the floor and ultimately was signed into law. I was assured that it was written in a way that could be implemented for good, to ensure patients were protected from surprise medical bills, to encourage insurance companies to expand their networks, and to give providers fair compensation for out-of-network services. It evidently must lack the mechanisms necessary to accomplish some of these core objectives. We know that arbitration is occurring as intended, and according to recent reports, providers are more often winning than not. However, but I hear on a regular basis that from those who have, in quotations, won at arbitration and just aren't being paid what they're owed by the insurance company, in many cases not being paid at all. Thousands and thousands of claims. The decision just sits there, and plans are forcing doctors out of network inappropriately, then to leverage them for reimbursement rates under the No Surprises Act, which would be lower. So can HHS provide guidance to insurers that they must pay out arbitration awards within a set time frame? And are there penalties in statute that can be levied for noncompliance?
Congressman, as you know, in our regulations, we stipulate that the losing party must pay, and I mentioned it earlier, the losing party must pay within 30 days. Now, here's part of the rub.
Correct.
We are not part of the dispute resolution process, the HHS, and so when a resolution is reached, we don't hear about it. We don't get information.
Department of Labor?
I don't know if even the Department of Labor gets the information, because it's a dispute that's between the two parties. What I would suggest is that the winning party, usually and more often than not, it's the providers, that they contact our help desk that we've set up to provide services. So the quicker we hear about it, the quicker we can make sure we enforce if they're not getting their payments within 30 days.
Yeah, I mean, you realize that an independent small practice fighting
Absolutely.
against one of the behemoth insurance companies is
Absolutely.
David versus Goliath, right?
Absolutely.
And the insurance plans they got more lawyers and they got more money.
Absolutely.
So we're going to need the agencies to, I would specifically like to know if there are penalties in the statute for noncompliance that can be levied, and if there are not, should Congress act to give you or whatever agency it is that authority?
We have the authority to try to push on the payment, and I don't want to misspeak as far as how far authority goes, but it is an obligation, a contractual obligation, because when you engage in that dispute resolution, you have essentially agreed to live by the resolution. So we could probably assist in trying to make that enforcement.
Well, if we can look into that, because it's not happening.
Yeah, I'd be more than willing to work with you.
We got to look into that.
And by the way, I completely agree that the little guys who win, those are the ones that suffer the most.
They
And
do.
So, whatever we can do,
Okay.
work with you.
Secondly, and I'll be quick here, ghost contracting remains a problem with respect to the way insurers determine their qualified payment amounts for QPAs. When insurers calculate the QPAs that include contracted rates for physicians who do not actually bill for those codes, these ghost contracts can dramatically reduce QPAs, resulting in payment levels that do not reflect true market median in-network payments. Can HHS provide more guidance to insurers that QPAs should be calculated on volume-weighted codes actually billed by the providers in question? This is a problem.
I'm with you, but now recognize that we conduct those audits if we have the personnel and resources to do them. And right now, because of the volume of cases, so much of our resources had to be focused on getting ready for the dispute resolution. So I'm going to plead with you now, Congressman, to make sure you help us before our funding runs out. Please make sure that you allocate some money so we can actually do the audits.
Okay, because this would result in more accurate payments and thereby dramatically reduce the number of claims
Agree.
going to the IDR process.
Agree.
With that, I yield back. Thank you.
Gentleman
Thank
yields
you.
back. Mr. Hudson's recognized for 5 minutes.
Mr. Secretary, thank you for joining us here today. As you probably know, I sent a letter to the President and to Commissioner Califf on harm reduction and pending applications for smoke-free tobacco products just last month, with over 60 of my colleagues co-signing that letter. I know that right before this letter was sent, your department also announced a new smoking cessation framework to support quitting, and in your words, quote, for every American to have access to the tools and programs they need to quit, and encourage and assist all who want to quit and to do so," end quote. My concern stems from the fact this framework does not include any specifics on Center for Tobacco Products, besides simply recognizing the FDA regulates nicotine products. The Tobacco Control Act of 2009, which you voted for in Congress and was signed by President Obama, made harm reduction a key pillar of FDA's tobacco control strategy. The CTP receives $712 million a year. That's over the 15-year period. That's $8 billion, has over 1,100 employees. Yet the FDA, under your leadership, has only authorized a handful of alternative products. And these are products that are proven to be less harmful, but only a handful have been approved in the 15 years since the law was enacted. This approach ignores the 30 million Americans that continue to smoke and denies them choices. Some have called on FDA to ban products like Zen, a product that's 99% less harmful than cigarettes, which has proven to be effective in helping people quit smoking or move away from chewing tobacco. Unfortunately, some demand these safer products be kept off the shelves, yet do nothing to stop the sale of illegal vapes from China from consuming the U.S. market. This is a bipartisan concern that was raised as recently as last week when Dr. Califf was on the Hill. I know FDA touts authorizing 23 vapor products whose technology, frankly, is now a decade old out of the millions of applications that have been filed, but this isn't good enough. I know you've sent warning letters and small civil monetary penalties to retailers and have taken some steps to combat this issue of these illegal vapes, but this also is not nearly enough. I hope you'll do more to take on these millions of illegally marketed products. My question for you, does the Biden administration believe in the continuum of risk in nicotine-containing products? And if so, when will the FDA start authorizing products based on science as opposed to ideology?
Congressman, thanks for the question, and you actually gave a lot of information, detailed information. Let me try to respond by saying FDA is working aggressively to try to pull products off the market that are not only illegal, but are not effective in trying to move towards cessation of smoking. I will tell you, and you never said the word vaping, but if we're talking vaping and e-cigarettes, FDA is working aggressively to make sure that no product gets in the hands of, especially kids, because so many of these products are marketed to kids illegally, that we make sure that we're going to move to make sure that if you want to market a product, it actually does what you say it does. And I can tell you that I think they got close, more than 1 million different applications to market certain products. They've had to reject the vast majority, in the upper 90 percentile of those products. They're continuing to work forward. Obviously, they are taxed because of the number of applications they've had. And as you know, in many cases, they end up in court because some of these larger vaping companies know how to slow down the process. We're going to do everything we can, but more than willing to work with you on this.
Well, I appreciate that. And at the end of the day, we've got products that are safer than smoking that we ought to be approving. And then we've got these illegal products that are being illegally marketed to children that we need to do more to stop and get them off the shelf. So I appreciate you working with that.
Thank you.
Want to switch topics here to a topic that's more directly impacting my state that we've talked about in your previous visits. As you know, for the last 2 years, other members of my delegation and I have tried to conduct oversight and provide clarity to our constituents about the developments of HHS's Greensboro Influx Care Facility, which I understand recently changed its name to Greensboro Children's Center. However, throughout this whole process, we've been frustrated by your lack of transparency to Congress and to our state. In fact, in 2022, your staff was on the ground in Greensboro discussing this site the same day you were sitting at this table testifying under oath that you had no plans to house any children in North Carolina. And you can understand, I hope, that the frustration that not only did that happen, but since, it's been really hard to get information from you, sir. And another example was your department's announcement to operationalize this facility on March 15th, despite the fact that my colleagues and I were still waiting for answers from you from your hearings you appeared at here in July and November of last year. We sent another letter and got some answers from you, sir, but we just want simple answers about what's going on here at this facility.
So, Congressman, you've always been very gracious with me, and I hear what you're saying, but I'm looking at it from the opposite side, and here, let me give you my perspective. When you all asked me the question, were we considering a site in Greensboro for our unaccompanied migrant program? We did not have any plans to establish a site in your state or in Greensboro.
But you had staff on the ground that day looking at a site in
Just
North
as
Carolina.
today, we have staff throughout the country looking, because we have to constantly look for places to make sure that we have accommodations, because we have an obligation to make sure a child has a safe place to be. DHS, Department of Homeland Security, Customs and Border Protection, they don't have sites that are equipped to handle kids. So we have to always look for sites. So when you asked me, did we have a plan to establish a site? I told you the honest truth. But I can see from your perspective, because you heard that maybe we were looking. We did ultimately find a site in Greensboro that seemed promising, but it today has no children in it, because that's how long the process takes. We have to go through, as you can imagine, a lot of hurdles before we can say a site is going to accommodate children. And we go through it very thoroughly. So as we speak, we are looking at sites throughout the country to make sure we're not caught flat-footed when we need to have a safe place for a child to be.
Okay,
So
I've gone way over time here. I've got other questions I'd like to submit. I would just ask you, please be more transparent with us and help us
commit
get
that.
information so we can
will.
assure our constituents. And
You
with
got
that,
it.
Mr.
Thank you.
Chairman, I appreciate your indulgence. I yield back.
Gentleman yields back, and Mr. Carter, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Secretary, thank you for being here. I think I don't doubt your intentions. I think you and I agree on the same thing. We want to lower drug costs. You didn't have the same experience that I had, serving as a pharmacist for over 40 years, having to go to the counter to explain to the patient how much their medicine was and watch them make a decision between buying groceries and buying food and buying their drugs. I had that experience, and I know you didn't have that experience, but I have to tell you that I feel like that your promises fall flat. You and I, the last time we had the opportunity to speak, and I believe it may have been in the Budget Committee, I'm not sure, but nevertheless, we talked about the government price controls of the IRA, which I think is the very worst legislation that I have ever seen in my 10 years in Congress, my 10 years in the state legislature. It is nothing more than it is not negotiations, it's extortion. And I hope that the court cases are going to prove it to be just that. Already it's resulted, and I don't mean to get back into it again. We had this discussion last time, because you say you think it's going to result in more cures, whereas the University of Chicago says it's going to result in 329 fewer cures in the next decade. Even CBO says it's going to result in fewer cures, yet you say it's going to result in more cures. I don't know how you justify that, but nevertheless, I'll move on for that, because I want to talk about something else. And what I want to talk about is copay assistance and the fact that the copay accumulators are being used by the PPMs and that they are pocketing this money. And yet the courts made a decision and made a ruling that they struck down the rule that allows insurers to implement these harmful programs, but your department is defying that decision and has gone on record as saying you will not enforce the court decision. Now, earlier, the chair of this committee asked you about the PBM transparency rule, and you said, well, we're going to respect the court's decisions. How do you respect the court's decisions there, but you don't respect them here? How do you pick and choose which ones you're going to respect?
Congressman, first, thank you very much for the question, and you're right. Every once in a while, we may disagree, but I appreciate the questions that you ask. We will comply with the law. That's our obligation.
Why aren't you complying with this one then? Why are you allowing the PBMs to pocket this money instead of it going to the patients as it should go to the patients? Because you know what's happening with these copay accumulators. And you know what's happening with when they have these copay assistance cards. They're not honoring them. And they're pocketing that money, and then the patients are having to either pay their copay when they run out, or when they get up to their stopgap, then they're having to pay more.
And we are, as I said, first and foremost, I can assure you that we will comply with the law. What we want to make sure at the same time is we don't allow the Medicare program and Medicare beneficiaries to get gamed in the process and ultimately end up having to pay more out of pocket at the end of the day.
How are they getting gamed here if they are not able to use these copay assistance cards that the PBMs are pocketing it instead of passing it on to the patients?
Congressman,
And the courts ruled that. But you're ignoring the courts, and you've even said we're not going to enforce it.
Well, I recognize what the courts ruled here. I recognize what they looked at, and they were looking at the facts that were before them. We have to make sure that we run the Medicare system so it works for all the 66 million beneficiaries that receive Medicare services. So what we want to make sure is that in the process of coming up with a system to not only dispense and allocate drugs, but to pay for them, that the folks who don't end up paying the higher prices are the Medicare beneficiaries themselves. And so that's
I'm
what we
not
have
sure
to
I follow that. Again, this appears
I
to be a
think
case.
you do.
No, I don't, and I don't think you do. With all due respect, Mr. Secretary, I don't think you do, because these copay accumulators are not being honored by the PBMs. They're pocketing them. How is that impacting someone else? I don't understand that when it's not impacting the patient, when they're not getting the credit for it. But let me move on. Earlier you said, again, in this minute, I've said here the whole time, and in this hearing you said, I promise you that I'm not going to do anything that impacts patient access to care. This impacts patient access to care.
It does not.
It does. How does it
not.
not?
Patients will still have access to the drugs that they need.
If they can't pay for it, that's why they're getting the copay assistance.
Under the Medicare program, they will have help with accessing the drugs that they need. That's unfair for you to say that any patient will be denied a drug.
It's unfair to you to
Give me
say
a
that we're
case-
going to follow
give
the
me a
law
case
when
where
you
a patient
pick
has
and
been
choose which laws you're going to follow.
Give me a case where a patient has been denied their drugs. Give me a case.
Give me a case where the patient's not been given credit for the copay assistance. All kind of cases, and you say, even though the courts have ruled that that's not right, you're not going to enforce it.
All right, I'm just asking you to prove what you just said. You just said that patients are going to be denied their drugs. Show me the case.
Patients are denied their drugs when they
Show
get
me.
the copay assistance,
Show me.
and they cannot afford it because it's not honored by the PBM.
Show me.
I will get those cases to you, and you get me a situation and show me where you make the decision on what court cases you're going to follow and what court cases you're not going
We
to follow.
will abide by the law.
You will abide by the law. You just said you're not going to enforce this one.
Carson, I just told you, we will abide by the law. And we'll make sure that no patient under Medicare is paying more than they need to for their drugs.
But when it comes to the copay accumulators, you're not going to honor that.
We're going to follow the court rulings wherever we can. I mean,
But you've said that you're not.
however we can. I didn't say that. I just told you we're going to abide by the law.
You know, I don't understand how everybody else is wrong and you're the only one who's right. I just
No,
don't get that.
I'm just asking you to show me the cases where
time is
people are being denied their drugs. Please show me the cases.
You know, Mr. Secretary, I'm sorry, but this is a total failure, and I yield back.
Gentleman yields back. Chair recognizes Dr. Joyce for 5 minutes for questions.
Good afternoon, and thank you for appearing, Secretary Becerra. Let's go back to an earlier discussion that you started. In the No Surprises Act, Congress rejected inclusion of federal benchmark payment standard. And when there are disputes over payment rates, the resolution process laid out in statute lists mandatory and equally weighted factors that must be considered by the independent dispute resolution process, the IDR. One of these factors is the qualifying payment amount, the QPA, defined as the median of health plans' contracted rates, which should reflect a typical contracted rate for a particular service by plan and provider type in a particular geographic area. The QPA was not included as a final payment amount or a payment benchmark, only as a reference point for arbiters if payment disputes advances to the IDR. To date, I've heard multiple widespread concerns that the QPAs calculated by health plans are artificially low, and in some cases, lower than the Medicare fee-for-service rate. I've also heard from providers that health plans are overwhelmingly relying on the QPA as a default initial payment rate, even though the statute does not contemplate the use of the QPA in that manner. Section 102 of the No Surprises Act includes the explicit authority for an audit process of health plans. You mentioned that earlier. You mentioned the staffing issues to be able to achieve those audits. But since 2022, you have been required to report to Congress on these audits. Mr. Secretary, since you have failed to report to Congress on QPA audits, I would like for you to address today in front of us how many audits the agency has initiated, your agency, how many audits have been initiated, and how many of these audits have been completed?
Congressman, thank you for the question. And I know because you have been very engaged on this whole No Surprises Act implementation, that you recognize that the way the process and the system launched really made it difficult to proceed forward with a clear understanding of how it would be implemented well, because much of the implementation went to court. We also found that the number of cases coming through, complaints coming through, was dramatically higher. And so much of the data that would help us explain how No Surprises Act will function moving forward, especially when it comes to the independent dispute resolution process, are barely beginning to come in. And so when it comes to the audit, what we're trying to make sure we do is we get information as quickly as we can. And as I mentioned earlier, we don't always have sight. That independent resolution process, as you know, does not involve the HHS. So ultimately, the resolution, the end result, the outcome, we don't get information on that. And until we get information from some source, hopefully from the winning party, we don't have an opportunity to act to try to change things. And so I wish I could give you more detail and give you more data, but we're now only beginning to see the process evolve to a point where it's now functioning the way I think.
Have any audits been initiated?
I can get back to you on what audits specifically have been done and any results from that. Be more than willing to give you closer insight if you haven't already gotten that from us.
We have not. We have requested that, and thank you.
Let me follow up with you on that.
And I appreciate you follow up, particularly in writing, because we would ask for a prompt response. Number of audits that have been initiated, and number of audits that have been completed. I wrote a letter to you in April of 2023 expressing my concern over CMS' broad and overreaching definition of what a single qualified source of drug was. And when you select life-saving drugs to price set under the Inflation Reduction Act, I stated my disappointment that this overly broad definition, which could capture multiple drugs at once for negotiation, and highlighted the potential detriments of such a far-reaching policy and how that could affect current and future innovation. So today, I'm asking you the same question. Will your administration maintain the uniform standard supported by the FDA and consistent with the statute that a qualifying single-source drug would be defined as a distinct new drug application or biologic license application? In other words, will your administration commit to incentivizing innovation by ensuring that only one drug, not multiple drugs, is chosen at once for government price setting?
Congressman, first, we don't price set. Secondly, the process that we engage in to negotiate fairer drug prices is set forth by the law, by Congress. You all gave us the rules on how to do that. And we want to make sure that no gaming can occur so that a drug manufacturer can't use techniques to try to avoid having to have its drugs come under the price negotiation process.
But one drug versus a classification of drug. Will you commit that you will use this negotiation that you described to implement this in one drug versus a classification of drugs?
We are implementing the law as it was passed. Otherwise, the courts would have stopped us from doing so. So what I guess what I'm saying to you is that I don't agree with the way
So you're looking to the
characterize
courts for oversight as opposed to the intent of the legislation?
I'm sorry?
You're looking for the courts? You said
No. We've moved forward. We've made clear how we're going to do this. If someone didn't like the way we're doing it, I guarantee you they would have sued us. All 10 of the companies that own the 10 drugs that are part of negotiation today have taken us to court. And so what I'm saying to you is if we were doing something wrong, we would have
Joyce.
found out from the courts by now, I think.
My time has expired. I thank you for
Gentleman's time has
appearing today. I
expired.
yield.
Dr. Schrier is recognized for 5 minutes.
Thank you, Mr. Chair, and thank you, Ranking Member Eshoo, and thank you, Secretary Becerra, for being here today. Mr. Secretary, I want to start by just thanking you for the work that you and your department are doing to improve the health and the well-being of Americans. I know that is the ultimate aim. I also know that you can't comment on pending litigation, but I do share Dr. Joyce's serious and urgent concerns about the way that the carefully crafted No Surprises Act has been implemented, giving insurance companies way too much power and having really devastating effects on physicians and patients. I'm not going to ask you because I know you can't comment, but I would just ask that you fix this as soon as possible. Okay. I do have a question about social media and youth mental health. On May 23rd of last year, Surgeon General Murthy released an advisory regarding social media and youth mental health. And the advisory confirmed what we all know, that excessive social media use can lead to poor mental health, eating disorders, low self-esteem, poor body image, anxiety, depression. I will add, as a pediatrician, inattentiveness, poor sleep. And I believe we would all characterize the average of 8 hours per day that 13 to 17-year-olds use social media as being very excessive and leaves them no time to sleep. As a pediatrician, I've seen firsthand what has happened since social media became a thing and with the skyrocketing use. So this advisory included several helpful policy recommendations, which include developing age-appropriate health and safety standards for technology platforms, increasing funding for research, oversight, higher standard of data privacy. This committee had a hearing this morning. We are working on some of these things. I know that many of these recommendations will be interagency efforts with the FTC, but I would love to know what HHS's next steps are in terms of following through on these recommendations made by the Surgeon General. I'm feeling urgency about this as well.
Congressman, you pose a really good question because, again, our reach into some of this, it doesn't fit into any particular bucket. For example, SAMHSA, our Substance Use and Mental Health Services Administration, is working through its centers of excellence to try to provide guidance to states on how to address the well-being, especially of children, when it comes to the use of social media. But as you know, there was a lawsuit that was filed that essentially to try to restrict our ability to have conversation with some of the social media platforms on good practices and things to do. That litigation continues. I have to be careful what I say. All I can tell you is that—
There may be a role, instead of working with the companies, like we'll do that from our committee, but there may be a role for HHS here to do the outreach to parents and to kids in the way that we approached cigarettes and how it's Big Brother trying to manipulate you, teenagers, and to parents your kids. And I would love to see something like that come.
more than willing to work with you on that, and so long as you bring some money to the table so we can actually get that done.
Okay, I'm switching to SAMHSA. Fentanyl and kids. Schools are very worried, superintendents, teachers, and they have guidance from SAMHSA about how to talk about alcohol and how to talk about marijuana and smoking, but they don't have it for fentanyl. Can you get that to the schools? Because they're not sure how to address this problem, and it is a huge problem in the schools.
So, Congresswoman, I'm not sure which schools you're referring to, but we work closely with the state. Remember, our reach usually through the state health authorities, and we provide them with a lot of guidance, information. It'd be tough for us to go to each and every school, but we try to make sure that we reach kids with all the information.
If you could make sure that some sort of paper guidance from HHS, just like from SAMHSA, gets to the states so that they can get it to the schools, that would be excellent. I have one more question. Avian flu. If you go to Costco and you buy eggs, they are probably coming from my district. Wilcox Eggs is in my district. And so avian flu was a huge concern, tremendous concern about a year ago. And we don't know yet what will happen with this year's avian flu. We also never know how that will impact human health. And I was just wondering if you could tell us what HHS is doing with regard to being ready for addressing this year's H5N1 avian flu threat.
Congressman, we've been working for about 20 years on this. And while I can't say we're ready for whatever form of H5N1 virus may come at us, because it's always mutating, you never know when it'll be, we've spent the last 20 years preparing for avian flu if it should get to humans. What I can tell you is that we all have to be prepared. Right now, what we've seen is that cattle, dairy cattle, are being infected. We're working closely. This is a government-wide effort within HHS. You've got our Administration for Strategic Preparedness and Response working with CDC, NIH, and FDA within HHS. but we're also working closely with the Department of Agriculture and Secretary Vilsack, and all of us are working with our state health and ag authorities to make sure that we're going at this, getting the data we need to know what's going on, and then letting everyone know what to do. We're prepared to provide not just PPE, but medical countermeasures if something should happen, but we're trying to get ahead of this.
Thank you, and I'll follow up with the USDA about vaccinations for birds. Thank you, I yield back.
Generally yields back. Recognize Dr. Dunn, 5 minutes.
Thank you very much, Mr. Chairman. Thank you, Secretary Becerra, for being here today. I have some questions specifically about a new program housed in Asper. I'm excited about the mission of the Office of Industrial Base Management and Supply Chains, though, to be frank, I have some concerns over Asper's experience in executing on a program this size. So I want to highlight for you that Congress is watching. I think HHS needs to get this right and ensure that the focus remains on this critical need. I hope we can work together to make that a success. I believe in the shared goal of prioritizing U.S. investments in strengthening the domestic biomanufacturing industrial base, which makes us more resilient when future crises occur and enables us to surge production to meet demand for domestically produced medical supplies and products. This office aims to respond to critical lessons learned from COVID-19 pandemic. It'd be a disgrace for us to have to relearn all the same lessons again. I also want to support good-paying biomedical manufacturing jobs in the United States. So I think the creation of the Office of the Industrial Base Management Supply Chain, IBMSC, was a part of the elevation of ASPR to an operating division of HHS. Now, as you know, that office was implemented using supplemental appropriations. It was tasked with that critical medical countermeasures like drugs, vaccines, and therapeutics are manufactured in the United States, or certainly friend-shored, as it were. IBM MSC also aims to support innovative manufacturing technologies in the fill-finish capacities to better produce and distribute drug products and vaccines, et cetera. In your 25 budget, you requested $95 million at ASPR for the biodefense production of medical countermeasures and essential medicines, which would be managed by that office, as I understand. Correct? Okay, good. How is the new office of IBMSC within ASPR, how's it working to ensure these supplies are in fact manufactured here?
Congressman, first, appreciate the mention of the work that ASPR and BARDA are doing. And here I'm going to ask you for some help because this is what we're requesting. We don't know if we're going to get it. We haven't been getting the resources we need. We had a proposal to do domestic production last year and the year before, but we didn't get the funding to do it. How we would do it, BARDA, ASPR, they're ready to go. We've been doing some of this. COVID gave us the capabilities to do it. Our folks are raring to go. We have private sector partners who are raring to go because we would love nothing more than to know that the production of the most critical countermeasures that we need in case of a pandemic are accessible to us, and we don't have to go to China or anywhere else.
Yeah, I see if people approach us, or we have companies approach us all the time that are actually very, good American companies that are trying to manufacture and do that in America. So I think we can help them with that. Let me turn my attention to the IRA for a moment. The price part of that bill. So according to the Kaiser Family Foundation, the number of standalone drug plans is plummeting under this administration. It's down 29% since 2021, and it increased 34% under the Trump administration. So many analysts are actually predicting that the mass exodus of standalone drug plans in 2025 is going to leave Part D. That's when Part D redesign goes into effect, and it's going to leave these patients who take traditional Medicare no alternative for prescription drug coverage. It looks like our policy here is going to be to corral our seniors into HMOs that restrict their choices of physicians and treatments, or they don't get a drug plan coverage at all on CMS. Can you address that?
Yeah, I'd love to see what you're reading because that's not what I understand. What we're doing is making sure that drugs are actually going to go down in price.
Well, but the drug plans are going away. So the insurance plans for traditional Medicare, this is not the Medicare Advantage plans, the traditional Medicare, they will lack coverage.
Again, please share that.
I'm an old guy. This is a personal question.
But please share that information, because that's not what I'm hearing.
Well, I'm quoting the industry at large.
Well,
Our
I can
time is
understand
running
the
out.
industry. I can understand the industry's trying to spook people, but I'm asking to, so I want to see the data myself instead of relying on industry generated data.
Turnaround is fair play. You're asking us for a written response after that, okay?
Within 30 days, okay?
We'll do it. Thank you very much. I yield back.
Gentleman yields back. Recognize Ms. Barragan for 5 minutes.
Thank you, Mr. Chairman. Thank you, Secretary Becerra, for being here, for all you're doing. When I first walked into the hearing earlier, the chairman was in this opening statement and was talking about the border, and I thought I walked into the wrong congressional hearing. What I heard was expressing a disappointment that the budget request didn't address the influx of illicit drugs like fentanyl, which are coming across our border at a rapid rate. I just want the American people to know that President Biden had a supplemental request that had $850 million that he was asking for to help combat fentanyl from crossing the southern border, another $100 million for HSI, which is investigations from crossing the southern border regarding fentanyl, and the hiring of more Border Patrol agents for this very reason. So the President of the United States and this administration asked for money, millions of dollars, hundreds of millions of dollars. And it is Republicans who said no to that. So expressing a disappointment about the lack of money in the budget for that is a little rich, considering the President asked for the money and Congress, with the Republicans in charge, have said no. And with that said, Mr. Secretary, I'm going to move on to my questions I have for you. I want to thank you for all you're doing on health care, all you're doing in the space of women's reproductive rights, and all you're doing on Alzheimer's. And my first question is on Alzheimer's, Mr. Secretary. 85% of initial diagnoses of Alzheimer's are made by clinicians who are usually primary care providers. And half of these providers reported that they do not feel adequately prepared to care for those individuals. That's why I've introduced a bill called the ADAPT Act with my Republican colleague, Representative Carter, which would empower primary care providers to better diagnose Alzheimer's and deliver high-quality, personal-centered care. As the number of people with dementia is set to increase, how will HHS work to support workforce readiness, as well as access to treatments and services?
Congresswoman, thank you for the question and all the work you've done on this issue of dementia. We are continuing to work to try to make sure that as we graduate the next generation of physicians, nurses, that we have them going into the areas that we need them most. And so we are trying to make sure that GME, graduate medical education slots, are going into those spaces. We're trying to make sure that, as you just mentioned, a primary care physician gets training beyond what they currently get in most medical schools. I focused earlier on the issue of behavioral health, because too many family care doctors, too many internists are not really trained on behavioral health services, and that means someone going in with a child that has behavioral health challenges has to wait to get to a specialist before they start to get the care. Very similar to the question you're asking with regard to Alzheimer's. We would be very supportive of any initiatives, especially if they come with resources, so we can make sure we can implement that to make sure the healthcare workforce actually addresses the needs of the populations that we're seeing grow.
Great. Thank you, Mr. Secretary. I also want to thank you for a demonstrated commitment in the budget, to cut the cancer death rate by 50% over the next 25 years, which includes implementation of President Biden's Cancer Moonshot initiative. Every 3 minutes, someone in the U.S. is diagnosed with blood cancer. One such cancer is multiple myeloma, where early detection is key to effective treatments. My sister has multiple myeloma. She's only 2 years older than I am. Of course, our colleague, Republican Steve Scalise, has been battling multiple myeloma. And so I know firsthand, what he's going through with the stem cell transplant and ongoing chemomeds people take. Can you share the importance of funds for the Advanced Research Projects Agency to improve early detection of such cancers?
Congresswoman, ARPA-H, the agency you just referenced, unlike the National Institute of Health, when it engages in a research program. It is not the long-term 10, 15-year process that NIH usually goes through to try to get some innovative therapy on the ground. ARPA-H is meant to harness those innovative ideas that are out there in America but haven't yet been catalyzed with resources. And ARPA-H says, if you can get something going in the next 2 or 3 years, then you're in ARPA-H's space. And so something like the issue of cancer, if there's an innovative idea on how to address any number of cancers, ARPA-H is a great platform, so long as that proposal can get out there within 2 or 3 years.
Well, thank you. I'm interested in working with the agency on the Moonshot Initiative, especially on blood cancers, because there is no formal program at the Centers for Disease Control and Prevention, so hopefully we can get that on a bipartisan basis done. And with that, thank you, Mr. Secretary. I yield back.
Generally yields back. Recognize Mr. Pence, 5 minutes.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, for being here. And I've got all these notes I could read to you, but I've done a lot of talking about the nursing home minimum staffing ratios, and it kind of as just a conversation between the two of us. I'm in rural southern Indiana, 6th District, and staffing shortages for professionals, nursing, and doctors is just rampant. It's huge. In the nursing homes, we've got sometimes 30% more beds than we have the ability to staff, and yet the ratio would increase that. And I've done plenty of criticizing this, wrote to CMS in a bipartisan letter. But more importantly, I just want to hear your thoughts on the shortages out there. And I know there's some university training issues maybe we could address as well. We're not producing as many healthcare professionals, nurses, and doctors as the demand is. Just give me your thoughts on what are you going to do about it? What can we do about this?
Congressman, thank you for the thoughtful question. And this is a tough one because we know that in many cases, some of our families don't have a choice but to send their loved one to a nursing home. We want to make sure that when they send their loved one to a nursing home, they're going to get quality care. We also know that in many cases, the workforce is a challenge. And so what we're saying is the fact that we want to keep standards high so that you know that your loved one is being cared for properly should not be a reason why a nursing home says they can't achieve the workforce that they need. If you're going to say you're in a nursing home, you should have a nurse in your home. And too often, Americans are finding that that's not the case. Perhaps that explains why during COVID, we have lost over 1 million Americans. About 20% of the people we lost are people who died in nursing homes.
Well, of course,
only 1%.
Most of them were over 65 and had had underlying conditions.
But remember, less than 1% of the U.S. population lives in a nursing home, but 20% of the people who died live in nursing homes.
So, well, I just want to share with you, Mr. Secretary, that I've gone out in my district. I go home every weekend, as I'm sure you did in the past. And what I'm hearing, you had an exchange with Dr. Dunn that, you'd like to see the reports and the data on that. I get it straight from not just the nursing homes, with the hospitals and the doctors in rural America. We don't have enough. We just don't have enough. And so I understand what you're saying. More is better for care. I get that. But it's saying that you have to have even more. I'm here to tell you that there's not enough trained people out there. I'm sharing that with you, okay?
But Congressman, I ask, when you say there are not enough trained people out there, does that mean that a nursing home is trying to take care of your loved one and my loved one without enough people or without enough trained people?
To hire.
Excuse me?
To hire.
Right, but if they're not hiring people because they say they can't find them, is it appropriate for them to say that they could care for your loved one or my loved one?
No. Why don't we, first of all, we have to identify the problem before we can fix a problem. And the problem...
But they're not waiting.
They're opening up their doors. You want to add more requirement when there's not even enough people now for that nursing home to fill the beds they have. I'm reporting, I'm not debating with you, I'm reporting information to you.
Yeah, and Congress,
That we had, I think, 7 people here. 6 of them said exactly what I'm saying to you. There aren't enough people out there to hire, but it's not just the nursing home issue, okay? It's also in rural doctors, hospitals, and healthcare professionals, the back office. So I'm here to tell you about that today, okay?
yeah, what we're hearing, and when we put out our rule, our proposed rule, and we got comments in the thousands back, what we were hearing were things like residents in these nursing homes lying for hours in soiled diapers. We were hearing about residents who needed to help to eat, struggle to get help to eat. We were hearing about people who were going through circumstances which you and I would just completely object to.
Okay, I understand that.
Yeah.
I understand that.
And so what we're saying is, wait, if you're gonna open your doors and sell yourself as a nursing home, then you shouldn't open them until you're ready to actually give people the care they need.
So, in conclusion, my time is up. We need to address the shortage in healthcare
Absolutely.
providers.
And we
okay?
put out tens of millions of dollars to help the industry. Not enough, but we're trying to help bring up the
I
workforce.
think we need to train them.
Okay.
Thank you.
Thank you.
Mr. Chairman, I yield back.
Gentleman yields back. Now recognize Ms. Dingell. Ms. Dingell for 5 minutes.
Thank you, Mr. Chairman. And Mr. Secretary, it's good to see you. I'm not sure you're having the most pleasant afternoon, but it's always good to see you back in the House. And I appreciate the opportunity to be able to highlight a few of our priorities in the fiscal year 24 HHS budget. First, let's discuss long-term care and home and community-based services. As you know, caregiving is the foundation of our economy. It allows for all other work to be possible. No care worker should have to live below the poverty line to do this work that millions of Americans depend on. The fiscal year 2025 budget includes a 10-year, $150 billion proposal to expand Medicaid, home and community-based services to allow more older adults and people with disabilities to receive care at home. Mr. Secretary, could you expand on what type of services would be provided and how this will improve the quality of life for seniors?
Congressman, thank you for that, and I know you know this issue so well. I do too, from having provided this type of care. Not everybody is fortunate as you or I to be able to afford to do it, and we understand that the best care for our loved ones comes from home. And so the more we invest in providing care at home, the greater the chance that the life of our loved one will be as good as it can be for as long as it can be. Here's the difficulty. It's tough to hire people who will do this and come to our homes and do it right. And the president's budget calls for $150 billion. Most of it is to make sure that we're getting qualified people to be the caregivers in our homes. It's also to make sure that if you as a relative are willing to take on the work, some would say the burden of caring for your loved one at home, then you should not be excluded from getting some compensation for the work that you've done. Because if you end up having to send them into some place where Medicaid has to pay for them, taxpayers are paying that bill. But when you do it, you're saving taxpayers a ton of money. And so we want to incentivize home care because it is the best care. You and I know that, and we want to try to invest so it's a professional workforce that's caring for our loved ones. And you and I, where we can afford it, but others can't, others should not be denied the opportunity to do what you and I did.
Agree, and I just want to highlight, but keep going, the point that it actually saves money.
Yes,
it does good.
Yes,
it
it
saves money. Now let's turn to supporting and improving rural EMS needs, or siren grants. The funding from the Substance Abuse and Mental Health Services Administration goes towards supporting rural EMS agencies in training and recruiting staff, conducting certification courses, and purchasing equipment in the grants. I lead a bill, the siren reauthorization, that would extend funding through fiscal year 28. It passed the Senate, and I hope for the same fate in this chamber. I want to emphasize how these emergency medical service agencies play a critical role in every community across our country. They respond to all kinds of crises, often risking their own safety, and work around the clock to keep Americans safe. But EMS cannot fulfill their important mission without a strong workforce. Mr. Secretary, can you provide an update on siren grants, and can we expect siren grants to be extended through fiscal year 28?
Congressman, that last part about how far it'll be extended is really on you all in Congress and what kind of resources you give us. We are sending out the second cohort of grants under this program in 2024. We believe, as you do, that the more EMTs are prepared and trained to take on all of these challenges, especially in rural communities, we're going to not only save lives, but improve health.
Thank you. And I also want to go to drug pricing quickly. You are doing a great job of implementing the historic provisions in the Inflation Reduction Act. First round of negotiations is underway. Can you describe how the various drug pricing reform provisions enacted as part of the IRA are improving the lives of Medicare beneficiaries? And how will beneficiaries save money when the $2,000 annual out-of-pocket cap takes effect next year? And what impact are the inflation rebates in the Medicare Part B and Part D programs already having?
Congresswoman, and I know you're very aware of the savings that seniors and Americans with disabilities are going to really see from the Inflation Reduction Act and its role in prescription drugs. Clearly, insulin, the fact that today Americans are benefiting by only paying $35 a month for their insulin is a game changer. But the fact that we're going to negotiate prices, in some cases, drugs that cost more than $2,000, $3,000 each time, that's going to be big because you just mentioned, starting next year, the most that any American in Medicare will pay out of pocket for their drugs will be $2,000. So you may have one drug which costs you more than $2,000. That's all you'll pay out of pocket.
Thank you, Mr. Secretary. I yield back, Mr. Chairman.
Gentlelady yields back and now recognize Mr. Crenshaw, 5 minutes.
Thank you to the chairman and ranking member. Thank you, Mr. Secretary, for being here. HHS deals with a lot of stuff, so you've gotten a lot of different questions today, and you're going to get another one. I'm only focused on 2 pages. I'm focused on 2 pages of HHS guidance on quite a controversial subject. Well, it's controversial up here. It's actually not very controversial in the public. It involves gender-affirming care on young people, on children, on minors. It's not controversial in the public. 70% think that we should not do gender-affirming care and hormone therapy, puberty blockers on children under 18. I bet that number is much higher if you ask them about, a double mastectomy on a 12-year-old girl. And yet, HHS guidance, it's only 2 pages, is very clear in what HHS believes, which is that gender-affirming care is great. There's nothing but good things coming out of gender-affirming care. You should just believe a child immediately if they say they're a different gender and put them first on puberty blockers, a month later on hormones, and then put them in the physical body that they believe they should be in. I mean, that's very, very radical stuff and obviously very consequential. You're making permanent physiological changes to a child, and you would think that if you're going to do something like that, that we would have an unbelievable amount of evidence to show that it indeed results in positive outcomes. I mean, you'd agree with that at least, right? That you'd want the evidence.
So first, Congressman, I have to say that nowhere what you've described do we say in any document from HHS. We do not make these flat statements, as you've said.
All right,
What we do is say we follow what the medical practitioners
I'll read
say
it.
is the
I'll read it
best
for you.
science.
If you don't believe me, I'll read it for you. So this is from HHS Office of Population Affairs. It says, it allows children, adolescents to focus on social transition and can increase their confidence while navigating the healthcare system. Research demonstrates that gender-affirming care improves the mental health and overall well-being of gender-diverse children and adolescents. Medical and psychological gender-affirming healthcare practices have demonstrated to yield lower rates of adverse mental health outcomes, build self-esteem, improve overall health quality for transgender, gender-diverse youth. Nowhere in here does it say there's any possibility of anything bad happening. Nothing negative at all in these 2 pages. It says that puberty blockers are reversible. There's really no evidence for that. Anytime you cite something in here, it's a study that is at the most recent is from 2021, all of which have very serious problems with them. They're all surveys, first of all. They're not really studies. There's not like a double-blind, randomized control trial going on here. And in some cases, 14% actually received the hormones. And many of these studies, they're not even just on children, and most of the participants are over 18. So you can't really determine any kind of causation. And bottom line, none of them are systematic reviews. If nothing else, you might agree that systematic reviews are the gold standard of evidence, right? A systematic review, for anyone listening, doesn't mean a study, it means a systematic review of all of the studies. One just came out, like last week, the CAS review, which, we're just gonna put up this, this diagram here. One of the things it pointed out was how all of these studies that have been cited by all of these radical ideological medical associations that are lying to parents and doctors showed how they cite each other in this sort of circular reasoning in order to make their point. And HHS should not fall victim to that. HHS you are relying on studies that match this much paper. These are the studies that you cite. This is the CAS review that just came out. That's a systematic review. That's the evidence that they're pushing out. That came from the British doctor, Hilary Cass. That's a huge difference in evidence. And that's a really big deal when we're talking about something as consequential as permanent physiological changes to children. I mean, right? Can I get maybe some agreement from you that you might want to take another look at this particular document from HHS, which is relying on old data, data that's from studies that have really been debunked in many ways. Can we at least look at it one more time?
Congressman, I can assure you that we look at all studies because the services that we provide are based on an understanding what the best available science and evidence are. When we talk about a standard of care, it's not something we make up. It's based on what the major medical associations, by the way, those radical associations you mentioned, many of your colleagues are members of those so-called radical medical associations.
Yeah, and they would probably agree that they become radicalized. Let me tell you something about standards of care. The
so you don't want me to finish the answer?
Let me talk. The CAS review also studied, and they ranked 23 standards of care from all the countries. You know what's ranked second to last? All of the ones you're citing here. The ones that you guys use. They ranked last as far as standard of care practice, as far as how good they are compared to other countries. That's a really damning statement from a systematic review from a very, very well-respected group of doctors. You are not relying on the best data. You're just not. And that is terrifying for our children. I'm out of time and I yield back.
Gentleman yields back. Countries around the world are banning this stuff. The United States is behind. I recognize Mr. Balderson, 5 minutes.
Thank you, Mr. Chairman. Secretary, thank you for being here today. I believe that digital health technology have the potential to change the entire healthcare ecosystem. Patients using digital health tools are empowered to better control their conditions and often catch problems before they become deadly. Rural patients, like many of those in the congressional district that I represent, can save time and money by not traveling long distances to brick and mortar clinics. However, at every turn, your administration has denied patients access to these innovations. Your department stopped the flexibilities for remote patient monitoring. The new reimbursement structure means many physicians cannot afford to invest in RPM program. Your department stopped the Medicare coverage of innovation technology, or MCIT program, and instead created a watered-down version that only offers coverage to 5 new technologies a year. This leaves more and more devices stuck in the valley of death between FDA approval and CMS coverage, and more importantly, leaves our seniors without technology that could better manage or even cure their conditions. Lastly, your department stopped one innovation technology-based health plan from staying in the Ohio Exchange, despite the price transparency it brought straight to patients and the savings it brought to employers. Mr. Secretary, my question is this: why has HHS, under your leadership, been so content with the status quo?
Congressman, we are not content with the status quo, and I would challenge much of what you just said, because what you're not recognizing is that Congress is the one that set the rules for telehealth. Congress has to extend the flexibilities. We can only implement and execute based on the flexibilities you all give us. As you know, come the end of 2024, some of the existing flexibilities that we have will expire unless you all extend them. So we have to comply with the law. If you don't like the law, you should change it.
Okay. I'll remember that. What is the total estimated time amount the taxpayers spend on premium subsidies for people making over $100,000?
I'm sorry, say that again?
What is the total estimated amount of taxpayers of what they spend on premium subsidies for people making over $100,000?
I know I don't have that particular answer, and I don't know if we can give you a specific response, but I'm more than willing to follow up. I want to make sure I'm clear so my team can hear it as well. You're asking how much are taxpayers providing in assistance through the subsidy program under the Affordable Care Act for Americans who get their coverage under the marketplace and the ACA?
That is correct. The CBO previously said it's at least $7 billion.
I'll try to get back to you with an accurate number if that's not the case.
Thank you, sir. At what income level do you think people should no longer get taxpayer-funded health insurance?
Well, that's pretty much set forth by law, so it's not what I want or believe, it's what the law says.
Okay. Well, the $7 billion could be instead used for expanding our seniors' access to innovative health care. I want to thank you today for your time, and I'll have more questions for the record, and Mr. Chairman, I'll yield back. Thank you, sir.
Thank you. Gentleman yields back. Recognize Ms. Craig, 5 minutes.
Thank you, Mr. Chairman, and thank you for your resilience here today, Mr. Secretary. More Americans have health care today than ever before, thanks to the ACA. And the expansion of those tax credits included in the Inflation Reduction Act. Enrollment and coverage through the ACA marketplace is at an all-time high, and a record high of 21.4 million Americans are now enrolled in coverage. In fact, in my home state of Minnesota, the uninsured rate has been cut in half compared to 10 years ago. On that note, Secretary Becerra, can you talk a little bit more about how the subsidy expansions included in the IRA are helping lower health care costs for families?
Thank you, Congresswoman. I think it's pretty obvious when people recognize that so much of the cost of health care occurs because people who don't have health insurance use the emergency room, the most expensive place to try to get health care. It ends up costing all of us money. It's also, when you think about it, the emergency room, it's the last resort. So someone is waiting till they're so sick, so bad, that they have to use an ER. Having your own insurance means that you don't have to wait. You can actually go see a physician ahead of time. And so we're saving billions of dollars by making sure people go early for their care and don't wait till they're so sick that now taxpayers have to cover the load.
Thank you so much. It's really heartening to know that the policies that we've championed and I've been part of voting for are delivering real savings to American families. Thanks to the IRA, millions of families have seen the cost of their monthly insurance premiums go down, and the average family is saving $2,400 in premiums a year. This budget includes a proposal to make those expansions permanent. Can you briefly discuss the importance of making the tax credit enhancements permanent?
You know, there's always someone who's right on the edge. They qualify for Affordable Care Act coverage in the marketplace to get a really good insurance plan, but all of a sudden, they're lucky, they get a bit of a wage increase. All of a sudden, they no longer qualify. And the burden of having to cover the entire cost without any subsidies becomes too much. By making these subsidies permanent, what we're doing is making sure that a lot of Americans who aren't rich, but they're not poor that they qualify for Medicaid, are able to sustain that coverage for themselves and their families. And so it's a way to make sure we are healthy from the beginning.
Mr. Secretary, I can just say to you that one of the reasons I ran for Congress is because I wanted to sustain the ACA. I grew up in a family myself without access to health care coverage for much of my childhood. And, you know, I know my colleagues talked earlier today about cost of living across this country, but I'm proud of the reforms, especially in the last 6 years when it comes to health care, because we have lowered the cost of living for so many Americans, not just with the ACA, but also in capping insulin at $35 a month copay, which I was proud to lead that bill here in the House. I want to slip in one more question before I yield here. I'd like to turn to an issue that's been really top of mind for me in this Congress, and frankly, one that I don't think this body and its members and a number of administrations have paid enough attention to, and that's the fentanyl crisis, the opioid crisis in our country. With every step that we make toward preventing more deaths, it seems that the dark underbelly of the illicit drug market churns out new poisons 100-fold. I was very pleased to see President Biden sign my bipartisan bill, the End Fentanyl Act, into law last month. That legislation requires Customs and Border Protection to update its manuals at least every 3 years in order to identify new ways to prevent drug and human smuggling through those ports of entries. It's a critical step in the right direction, and I'm interested to know how our public health agencies are working to improve outcomes in concert with law enforcement. So, Mr. Secretary, in 30 seconds, how does the President's budget proposal support HHS with respect to these issues?
Well, I won't speak to the close to $45 billion that the President devotes for enforcement, especially at the border. I'll speak to the close to $9 billion that the President has in his budget to try to tackle opioid overdose and all the effects, which would include what fentanyl does. There is a particular program which I know your state and every state of every member here takes up, and that is the state opioid response grants. That is money that we give out to states so they can directly target that opioid abuse. Fentanyl is part of that. We also have a drug prevention strategy that makes sure that the best practices that are evidence-based are used, and so we invest in those. We're doing everything we can. $1.6 billion is allocated for those state opioid response grants. Another $1.5 billion is provided for SAMHSA to provide behavioral health services to help address opioid and substance use issues. So we're trying to make the right investments we can with our states.
Thank you so much, Mr. Chairman. With that, I'm out of time, and I yield back.
Generally yields back. More overutilization of the ER is done by Medicaid patients than the uninsured statistically. So good insurance actually matters, yes. I want to recognize former member of this committee, Congressman John Shimkus, who just walked into the room sitting back there. Now recognize Ms. Harshbarger for 5 minutes.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, for being here. We've seen large advancements in access to care in the last 4 years, particularly in rural areas, thanks to telehealth and increasing access to pharmacist services. And I'm a lead co-sponsor of legislation, the Equitable Community Access to Pharmacist Services Act, that would provide Medicare coverage to seniors so they can have access to certain testing, treatment, and vaccination services at the pharmacy where permitted by a state scope of practice. CMS was able to provide access to these services during the public health emergency using waivers, but these waivers expired and Congress has to act to make these services available to our seniors again, sir. Is it correct that CMS cannot provide this coverage on its own?
If we're talking about the availability through telehealth, that's correct. Only because we were in that public health emergency world were we able to extend those flexibilities, but those expired when the public health emergency expired.
Okay. Will you work with us to advance this legislation next year?
Absolutely.
Great. I want to change topics, and on the topic of updating our country's dietary guidelines and alcohol consumption, a decision was made by your department to break a 40-year precedent and replace it with a new process. In the 2023 Consolidated Appropriations Act, Congress specifically allocated $1.3 million for the National Academies of Sciences, Engineering, and Medicine to study the relationship between alcohol consumption and health outcomes for incoming, the next edition of the Dietary Guidelines on Alcohol. But your department, this is independently and separately, also directed the Interagency Coordinating Committee to Prevent Underage Drinking, that's ICPUD, at SAMHSA to write recommendations on adult alcohol consumption, and a process that is duplicating and may intend to undermine the congressionally mandated effort already being carried out by NASM. Notwithstanding the fact that guidance on moderate alcohol consumption for legal drinking age adults is entirely outside the mandate of ICPUD. So why did you decide to redirect resources away from combating underage drinking to focus on adult legal consumption under the dietary guidelines?
Congresswoman, I'm going to acknowledge that you just You just gave me a good
Just
question.
laid it down, didn't I? Yeah.
Can
Well,
I
you-
follow up with you on that? Because
Yes,
I
sir.
don't want to give you an answer that doesn't respond. And
Okay.
I don't know, I can tell
Good
you right
to
now, I
know.
don't know.
Yeah, get back with me quickly.
We'll
okay?
do so.
Because,
Thank you for being patient.
Yeah, ICPUD, they don't have expertise on nutrition, healthy dietary patterns, and moderate alcohol consumption by adults. So if you'll do that, that'd be great. Okay.
Get back to you.
As you know, in January 2021, CMS approved Tennessee's groundbreaking Innovation Section 1115 Medicaid waiver program. It's known as TennCare 3, and it infuses the principles of value-based healthcare into the Medicaid program like it never has before. And this first in the nation forward-looking waiver puts guardrails in place to ensure appropriate oversight and protections for beneficiaries while also creating incentives for the state to manage cost, while holding them accountable for improving access, quality, and health outcomes. And it's no exaggeration to say that this has been carefully crafted and its demonstration is an unqualified success. So can you explain how the department intends to respect states like Tennessee's ability to innovate as well as ensure flexibility to serve the unique needs of our particular populations?
Congresswoman, speaking generally here, we are very enthusiastic about states that want to innovate with Medicaid. The way we look at Medicaid, we should have left the days where a Medicaid dollar only reimburses if for a doctor visit or a hospital stay. But there are ways that a state can work with other state agency programs to ensure that a Medicaid recipient ends up healthier if by that Medicaid waiver program, you're combining a lot of different services. So we are absolutely interested in innovation. What we have to do, because I have to come back and testify before you, is show that those states are being accountable for the money. Show me that your Medicaid recipients are ending up healthier tomorrow from the Medicaid waiver that you got today.
Yeah, and who knows better than the state how to take care of its own population? So that would be a great program going forward, and can't measure something if you don't measure the outcomes. So with that, thank you, sir, and Mr. Chairman, I yield back.
The lady yields back. The chair recognizes Dr. Miller-Meeks for 5 minutes for questions.
Thank you, Mr. Chairman, and thank you, Secretary Becerra, for testifying before the Energy and Commerce Health Subcommittee. As a physician, I have unlimited endurance. I just want to follow up to Dr. Bucshon and a comment you made. So during 2012 to 2019, ED treatment cost increased from $54 billion to $88 billion, a 5.4% annual renewal growth rate. Treatment cost, ER costs, did not go down after implementation of the ACA. Just wanted to put that out there. When you testified before this subcommittee last year, I asked you if you would responsibly work with me on my legislation to implement algorithmic technologies at HHS to save taxpayer dollars by reducing improper payments, fraud, waste, and abuse. And you said we absolutely would look forward to working with you and that you are still trying to figure out how we can make the best use of AI and use it for the right purpose. We are in agreement that these technologies should not be used to deny legitimate claims and restrict access like what we see happening in some of the private plan spaces. My office submitted the legislative text for this proposal, and unfortunately, Representative Eshoo, I have to one-up you, a year ago for technical assistance, but we have not received it back from you. Yes or no, will you commit to getting this back to me within the next 30 days?
So
Yes or no? Yes or no?
I was about to say absolutely yes, but I want to make sure I
Thank you
qualify
very
because I
much.
want to.
No Surprises Act implementation has been a disaster. According to the GAO, over 61% of 490,000 claims submitted remain unresolved in June of 2023. This means that thousands of physicians nationwide are not being paid and potentially going out of business, selling their practices to hospitals, or retiring. And this is on top of what's happened with Change. What is HHS doing to improve the efficiency? More importantly, your department said that you had the ability to penalize after arbitration, but claims are still unpaid. What are you doing to penalize bad actors who are not paying after arbitration has shown that their claims should not have been denied?
And you may have, I don't know if you were here, Congresswoman, at the time, but I mentioned that the independent dispute resolution process does not involve HHS. So once a dispute is resolved, the winner in that dispute If that winner isn't getting paid by the loser, we're not aware of that. And the only when a winner comes to us and says, wait a minute, we never got paid, do we get informed of that? So what I would do is encourage any provider that wins that you know of to please reach out to us, to our help desk, so we are informed, so that way we can take action, because we are, under law, given the authority to try to enforce those judgments.
We will do that, and if it requires legislation which was not put in the No Surprises Act, in accordance with the guidance given to legislators by HHS, who said that they had the ability to, in fact, enact penalties or get this recoupment. So we'll follow up on that. Under the Biden administration, Part D drug premiums are going up, plan choices are evaporating, and formularies are getting tighter, largely due to Inflation Reduction Act reforms to Part D. Essentially, the IRA has increased Medicare costs for seniors and continued Democrats' goal of limiting health plan choices, and eventually the country evolves into a single-payer socialist healthcare system. According to National Cost Data Report on Medicare Part D premiums by HealthView Services, Medicare recipients nationwide will pay an average of 35% more in 2024 for prescription drug coverage compared to 2023. Seniors will continue to see narrow formularies, more prior authorization and utilization management, more step therapy, meaning that seniors are paying more for restricted coverage. Secretary Becerra, I'm concerned that your management of the Medicare Part D program and changes that are going into effect under the IRA will in fact drive up premiums and lead to less plan and prescription drug choice for our seniors. Part D premiums went down 11.7% under President Trump, but are up 22% from last year under President Biden. The IRA calls for increased risk plans starting next year when Part D redesign goes into full effect, and plan liability triples from 20% to 60% for expensive drugs. Have you performed any analysis on the IRA's impact on Part D plan design to see how much more restricted seniors plans will be compared to how they were pre-IRA, and how much more utilization management they'll experience?
Congresswoman, you just said a lot. I don't agree with much of it, but what I will tell you is this. Ask any senior on Medicare what they pay for insulin, and I guarantee you they're going to tell you they're paying a lot more. They ask a senior how much out of pocket they're paying right now for the prescriptions they need.
With all due respect, sir, the seniors in my district are all paying more for their drugs, but I will appreciate
That's on the drug companies, not on Medicare.
Your pre-IRA analysis.
Yeah, but
So
that's
thank
on the
you.
drug companies. The drug companies are the ones that set the prices, not Medicare.
Last question, my time's running out. In February of this year, the committee subpoenaed the National Institutes of Health for documents related to NIH handling of sexual harassment complaints from within the agency and its grantee institutions. There are over 900 files related to sexual harassment to be reviewed. As you know, committee staff have been conducting in-camera reviews at HHS of sexual harassment cases reported to NIH. During these reviews, the documents have been heavily redacted. HHS has redacted the names of the disciplined, terminated, resigned, or transferred abusers, including individuals who were convicted of crimes. There's no basis for protecting these abusers' names from Congress. This is unacceptable. By redacting the names of all the abusers, HHS is preventing Congress from seeing whether these abusers are still receiving grant funding, or even worse, if they're transferred to a new institution and were then given new grant funding. Why are you protecting the identities of the abusers and institutions who house them from being shown to Congress?
We're going to have to take that in writing. I'm sorry. We're trying to get to everybody before vote. So Ms. Kuster from the
Thank you. I
gentleman
yield
is back.
back.
Ms. Kuster is recognized for 5 minutes.
Thank you, Mr. Chairman. Secretary Becerra, you must be exhausted, but we're delighted you're here. You can see the light at the end of the tunnel. Great to have you with us. The Department of Health and Human Services plays a critical role in protecting the health and well-being of our country, and this budget proposal reflects just that. The budget reflects this administration's commitment to ending the mental health and substance use disorder crisis, was been my #1 priority for 12 years in Congress. Last year, the FDA approved the first over-the-counter overdose reversal medication, naloxone nasal spray. This is truly an exciting first step to making this life-saving drug more accessible and reducing deaths from overdose. And I'll point out, New Hampshire is the site of one of the very first vending machines for naloxone to make it available to everyone in the community. However, I'm concerned that seniors with Medicare Part D plans and Medicare Advantage plans may actually lose access to the drug now that a prescription is no longer needed. As you know, 52,000, excuse me, Medicare beneficiaries overdosed in 2022. The Office of the Inspector General believes this could actually be an undercount. The OAG also found over 1 million seniors enrolled in Medicare struggle with opioid use disorder, including relatives of mine. Secretary Becerra, what steps can be taken to ensure that seniors can access over-the-counter naloxone?
Congresswoman, you point out something that's critically important. Most folks think of young people when it comes to the need for naloxone to save a life from overdose. But we need to make that available to all people, including our seniors. We are right now in communication with Medicare Advantage plans and Medicare Part D sponsors to try to encourage them. Remember, we can't force them to do things. They are the ones that decide what they cover and what they don't. We don't have the legal authority to require them to do certain things. But we're talking to them because it just makes total sense. This is about saving a life. They might even save a lot of money by making sure naloxone is available, because if someone doesn't end up ODing, they may still cost a lot of money for the care that they're going to receive while they're in the hospital. So we're right now in the process of talking to the health insurance companies, those who offer Part D plans, to make sure they're clear. It makes total sense to make sure naloxone is available, even though it's no longer necessary through prescription, but can be available over the counter.
Thank you, and I hope that more plans will expand their supplemental benefits and take action to help seniors maintain their access to naloxone, and I stand ready to work with you on this important issue with my colleagues. I'd also like to discuss the work HHS is doing to better serve hard-to-reach populations. I applaud the Biden administration's effort to expand medication-assisted treatment and opioid treatment programs within the federal prisons. This is another area where I believe there's much work to be done, and I make it a priority in my months left in Congress. States and localities continue to struggle with the cost of providing mental health and substance use disorder services to incarcerated individuals under custody due to what's called the Medicaid inmate exclusion. Studies show, however, that for every dollar we spend to treat substance abuse in prison, we can save up to $7 down the road. That's a decent return on investment. We should maximize effective cost-saving treatments, and that's why I introduced my Rehabilitation and Recovery During Incarceration Act. This bill, which has bipartisan support, would reform the Medicaid inmate exclusion policy so that incarcerated individuals who are eligible for Medicaid can continue to receive mental health and substance use services. Secretary Becerra is our nation's top healthcare advisor and the former Attorney General of California. Can you explain how providing mental health care and substance use treatment in prison could actually keep our communities safer and healthier?
Congresswoman, we know that prison is supposed to be a place for rehabilitation. We know that most prisoners are at some point going to be released into the community again. It makes no sense to release someone into the community who is addicted or is still having behavioral health challenges. The more we do to get a prisoner ready for exit, the better prepared our community will be to bring them back into the fold. In fact, we are now making investments through Medicaid with states so that they can prepare those who are incarcerated in their process of exiting to be ready. So Medicaid will be available to them so they start right away with the health care they need. They may not have a place to live, they may not be integrated into society, but we'll make sure that at least health care is something that's available to them.
Thank you, and I encourage my colleagues to join our bipartisan bill, the Rehabilitation and Recovery During Incarceration Act. And it's a delight to have you with us. I'm so proud of your service. And with that, I yield back.
Thank you. The gentlelady yields back. Chair recognizes Mr. Obernolte from California for 5 minutes for questions.
Well, thank you very much, Mr. Chairman. Secretary Becerra, thank you for being here today. I appreciate your willingness to engage with us on the issue of the HHS budget. I'm one who believes that we don't have enough interaction between the executive and the legislative branches, and so the fact that you're here means a great deal to me. I'm a budget guy, and this purpose of this hearing is supposed to be to present the HHS budget for next year, and so I want to talk about the high-level numbers. So you're asking for a fiscal year 2025 budget of $130 billion in discretionary spending and $1.7 trillion in mandatory, for a total of about $1.84 trillion in budgetary authority. When I look and I compare that with last year totals about $1.7 trillion. So you're asking for about an 8.3% increase. One thing that stood out to me is that inflation over the last year has run about 3.5%. So you're proposing that we increase HHS spending by a rate that's over double the rate of inflation. Is that right?
We're not recommending it. In many cases, it's required because much of the increase that you mentioned is mandatory, which we don't have control over. It's by law, we have to provide it. So the Medicare beneficiary, the Medicaid beneficiary, that's automatic. And so if a population increases, as it has, a lot of the baby boomers are now into Medicare, we have to provide those services.
All right, so just projecting in the future, do you anticipate that in HHS spending will, on the path it's on, increase at over double the rate of inflation over the next few years?
Actually, I think if you take a close look, the discretionary part, which is the money that isn't mandatorily obligated, I think you're going to find that that's way, way smaller than what you, the percentage that you quoted.
Oh, certainly, but I mean, dollars are fungible, obviously, so when we care about the overall piece.
Not necessarily in this case between discretionary and mandatory. No, not necessarily.
Okay, we'll agree to disagree on that. Let me talk about this. Obviously, we have a problem with the federal budget. We're almost 30% in deficit. There are only three choices here. We can increase taxes, we can decrease spending, or we can borrow more money, and our national debt is already over $34 trillion. When you come to a budget with us with a budget that increases spending, I mean, that really is taking, spending decreases off the table unless we make statutory changes to the law that decrease that mandatory piece. Or we could increase taxes, and I know your budget proposal has a proposal in there for increasing taxes, or we can deficit spend. So, I mean, of those three options, what do you think we ought to be doing?
Well, the president's budget responsibly makes investments. So, for example, I think you and I would agree that fentanyl is something we have to take on. I don't think you're going to say, let's shortchange our efforts to try to keep fentanyl out of the hands of Americans. So we want to make sure we're making the right investment there. I think you would agree that we want to make the right investments with behavioral health. Today, more and more children are dying from suicide than ever before. I think we want to improve our services. And so where we're making the investments, I hope you'll agree, it's important to do so. The president, though in his budget, does make responsible choices in how to make sure we're covering the costs of much of what we're doing. And so I would say to you that the president's budget is extremely responsible because he tries to pay for what he does.
Sure. I mean, pay for maybe perhaps in the sense of incrementally, but overall, the president's budget does not balance the budget. There's still a substantial amount of deficit spending, and healthcare spending is what's driving that. So let me ask you this. I mean, we will probably spend 18% of our gross domestic product this year on healthcare spending. That compares with much lower levelers in other countries. For example, the UK, which has a socialized healthcare system, spends about 10%, maybe even less than 10%, and has, by a lot of metrics, better healthcare outcomes than we do. And there are other countries like Singapore that spend a third what we do and have substantially better healthcare outcomes. So by a lot of metrics, the United States has the least efficient healthcare system in the world.
I would agree.
So what should we be doing about that?
I had a conversation with my friend, the health minister from Singapore, and also from Indonesia on these subjects, and they do a lot more early intervention care, preventative care, so that way they can tackle health issues before they get really expensive, become chronic diseases. We don't do that well enough, and because we have a system of healthcare that is essentially governed by 50 states, not the federal government, you have a patchwork. Some states do better, some states don't. And if we could even that out and also focus early, my mom used to say, mejor prevenir que remediar, better to prevent than to remediate, we'd get to tackle those things better.
Yeah, I would agree with that, but also add that we need to restore the functionality of healthcare markets in the way that other countries have done. But I see that I'm out of time. I'd love to continue our discussion. Thank you very much again.
Thanks. The gentleman yields back, and the chair recognizes Ms. Trahan for 5 minutes for questions.
Thank you, Mr. Chairman. It's great to see you, Secretary Becerra. As you and I have discussed before, community hospitals around the country are facing significant financial challenges. And in my home state of Massachusetts, those challenges are being made worse by a private equity corporation that has prioritized profits over patients and jeopardized the future of the 9 hospitals it owns in the process. Mr. Secretary, as we speak, Steward Healthcare, the largest for-profit, private equity-backed health network in the country, is creating a healthcare crisis in working-class communities across Massachusetts, just as it did when it drove Texas Vista Medical Center in San Antonio, Texas, into closure last year when it was forced to sell off its hospitals in Utah just months earlier. Steward is facing a significant cash crunch because of blatant mismanagement by company executives who have rewarded themselves with multi-million-dollar salaries while accruing massive debts. Unsurprisingly, Steward has failed repeatedly, including in response to requests from myself and my colleagues in the Massachusetts delegation to provide transparency regarding its intentions to maintain the operation of their 9 hospitals in our home state. So instead, it announced the sale of its physician group to Optum, a subsidiary of United Health Group, while providing no insight into the future of the hospitals their physicians practice in or what the proposed sale will mean for vulnerable patients. So, Mr. Secretary, many of the hardworking families I represent just want to know what that their government is paying attention to this issue and taking action to keep their hospitals open. I'm hoping I can count on you to maintain a line of communication with Massachusetts leaders to ensure that every possible action is taken and resources available to keep community hospitals like Holy Family Hospital open and serving patients.
Congresswoman, we will do everything we can. This is actually a question more appropriate for me when I was Attorney General, because we try to take on some of these, I mean, they're vicious investors that essentially try to gut the assets out of an institution, and they just sort of run out of Dodge. And I can't tell you that we have authority because we don't govern the licensing of hospitals and so forth at the federal level. That's all state. But we are ready to work with Massachusetts to make sure healthcare is available to communities.
I appreciate that. And I am encouraged by the recent work your department has done in collaboration with the Department of Justice and the FTC regarding the effects of corporate ownership trends in healthcare. And my colleagues and I plan to submit comments as part of that process. This year, I'm spearheading efforts to commission a GAO study on hospital closures in the last decade to identify the ownership models that have closed and assess the impact of those closures on their communities. This type of study has been conducted for rural hospitals, but not on a broader scale. If you could just speak a little bit to how improved transparency regarding hospital closures will help the agency to effectively address, respond to, and mitigate future community hospital closures, that would be great.
Yeah, we're actually doing something very similar to that with nursing homes. We are tired of seeing nursing homes that get bought up. Usually they're owned by, mom and pops, people who start them up for, wanting to help the community. Then they get bought up. And before you know it, you can't trace back who the actual owner is. So now we are requiring nursing homes to provide information on who the actual owners are, because they set up so many LLCs, and so many different sham corporations, it's tough to get to the bottom of it. And then when they run out of town, after they gut the assets, people are left wondering what happened. So we would love to work with you on being able to have more transparency in the healthcare sector.
Thank you. I do believe that, we can agree that as we address closures and acquisitions that don't benefit patients, that it's crucial to distinguish corporate for-profit hospitals from their nonprofit peers. I introduced bipartisan legislation with Congressman David Valdeo to establish a federal designation for essential hospitals. And I hope my colleagues on the committee will support this legislation. I hope to work with you, Mr. Secretary, to better support the essential health systems that all of our communities depend on for life-saving care. Thank you, Mr. Chairman. I yield back.
Gentlelady yields back, and that concludes all members of the subcommittee, and we have 2 wave-ons, and remember, there's a vote on the floor, so we'll go quick. Chair now recognizes Mr. Pfluger of Texas for 5 minutes for questions.
Yeah, thank you, Mr. Chairman. Mr. Secretary, are you the principal advisor of the President of the United States on unaccompanied alien children?
Congressman, the Office of Refugee Resettlement is the agency charged with them.
Understand.
We work with the White House in making sure that we.
Are you the principal, as the Secretary Cabinet member, are you the principal advisor?
I am the Secretary of the Department of Health and Human Services,
Okay.
and ORR is.
So you
within
advise
HHS.
President Biden normally on unaccompanied alien children?
We work with the White House.
Yeah, but you advise.
We work with the White House, we offer advice, we take their direction, and we work together.
Are you a cabinet member?
I am a cabinet.
Okay. How many children are unaccounted for right now?
I'm sorry, how many children?
How
What?
many children are unaccounted for?
In our care?
There's been reports that through open press and media that unaccompanied alien children who leave the care of ORR are unaccounted for. Their whereabouts are unaccounted for. Can you answer that question as to the number?
There are no kids who are unaccounted for who are in our custody and our care.
Understand. Do they all have a place where they have gone that is a safe place, that they are not being either abused or that you feel good about where they are?
The children who are in our custody, I feel very good about what the care that they're receiving under our custody.
When they leave your custody?
When they leave our custody, they don't leave our custody until they've gone, they have gone through a process where those who are willing to become the sponsors of the children go through a thorough vetting process.
So the recent OIG report on ORR's handling of...
Which recent report are you speaking to? The one that's from 2021 or something recent, meaning this year?
Yeah, more recent than 2021, refers to the handling of these UACs and deficiencies in safety checks, deficiencies in the overall handling, the monitoring procedures. Can you kind of talk to me about what that looks like and what your office has done to address that? And are you following the OIG's guidance on that, and what steps have you taken?
First, we always work closely with the Inspector General's office, and we try to follow through with them on all of their recommendations. The report I believe you're referring to is a report that's based on information that they got from early 2021. What I can tell you is that some of the circumstances, if you recall, that's when ORR, because the previous administration had dismantled the operations of ORR to take care of kids, it was becoming difficult to find places to house them. And so we went through a process, and
I
today...
think that's really what I'm getting at is, there are multiple reports that children have been lost, quote unquote, in the system. So
We've not lost any children.
Zero.
We've not lost any children.
Okay.
Those who are in our care, we have not lost.
Okay, so everyone is accounted for.
All the children that we have jurisdiction and custody over are not, we know where, we have them. We don't lose them.
Okay. I want to refer back to my colleague, Ms. Miller-Meeks. The question she asked that you weren't able to answer because of the time, and I'll just ask the question, but she outlined it. Why are you protecting the identities of the abusers and the institutions who house them from being shown to Congress, even though that was subpoenaed by Congress this year?
So I think it's first important to say that if there is an abuser that is receiving taxpayer dollars from the Department of Health and Human Services, or in this particular case, to the Congresswoman's questions, from the National Institutes of Health, we will take action immediately.
Why are you not releasing the names to Congress?
Again, when we act, we have to act according to the law. And there are still laws that protect privacy interests, so we can only provide certain information.
Did you receive the subpoena?
I know the department received a subpoena.
Did you actually physically read the subpoena?
I saw the subpoena.
So you read it. And did it ask for the names?
Because the subpoena asks for something doesn't mean that...
Doesn't mean you're going to comply with it.
We're going to comply as best we can to a subpoena, but we have to follow the law in complying with any subpoena.
Can you tell me on what legal basis you are referring to that you would not release those names according to the subpoena and the request?
As I said, we have to make sure we follow the process, whether the process is in protecting
But
privacy.
You've read it. We've established that. What part of the law is preventing you from releasing those back to Congress?
Well, as I said to you, there is a process for adjudicating any particular case where there are accusations of sexual assault, sexual harassment, and we have to follow that process pursuant to the law.
Do you plan to release the names to Congress?
We'll release whatever the law allows us to release in due course.
Do you think that is going to allow you to release the names back?
It's hard for me to prejudge what's going on in adjudication.
Okay. I think in the interest of a subpoena, it would be good to get back to Congress on that subpoena with the reasons stated why you would or would not release those names.
Congressman, you're
And
speaking
that's
to
the
a
reason
former
my
Attorney
colleague-
General. I understand the value and importance of it.
I think that's the
Make sure
frustration
that
of
we
why
abide
my
by the law.
colleague asked that question, because that has not happened yet. With
I think
that,
we
I
got to
yield
get
back.
one more questioner in. So thank you. And the gentlelady from Florida is recognized for 5 minutes.
Thank you, Mr. Chairman. Welcome, Secretary Becerra. Before I dig into the budget, I did want to commend you on two things. First, you finalized the rule relating to short-term limited duration plans known as junk plans. These are the plans that the former president and former administration tried to extend. They don't include care often for pre-existing conditions. And when you combine that with the unscrupulous, deceptive practices of a lot of scam artists out there, it was really great to see you crack down on junk plans and return them to where they were intended to be, short-term gap coverage. And I don't think we can celebrate enough the success of the Affordable Care Act enrollment. Coming from the state of Florida, where we have many challenges when it comes to health care coverage, the Affordable Care Act has been a lifeline. And that has been an important partnership based upon what Congress did to help lower costs through the Inflation Reduction Act, but what you all did on outreach, everything President Biden did to stand up to make sure families knew that the ACA was there for them. Florida, again, led the way in marketplace enrollment with 4.2 million Floridians selecting high-quality, affordable plans. That's almost 20% of the country's 2024 enrollment of over 20 million people. So thank you for you and your team's continued support of the ACA and the healthcare navigators that are doing the hard work day in and day out to make sure folks are connected to coverage. Now on to the budget. I was thrilled to see your legislative proposal to improve children's access to care, allowing states to expand continuous eligibility to children in Medicaid and CHIP from birth to age 6, and allowing states to provide 36 months of continuous eligibility for children until they turn 19. This 36-month period between redeterminations would build on the 12-month continuous eligibility protection for all children in Medicaid and CHIP. It's been championed by this committee. It went into effect in January, but children often lose coverage, more so than adults, due to procedural reasons, not because they're not eligible, but often there are other barriers in the way. Can you talk about help us paint the picture on why so many kids inappropriately lose coverage and why you have targeted better continuous access to coverage for young people across America?
Congressman, first, thank you for your help in making sure Florida just hit it out the park. Floridians, I should say, because we didn't always get support from the government in Florida, but Floridians really hit it out at the park when it came to getting coverage. And now they have the peace of mind that comes from being insured for health care. On Medicaid, children, what we found, and we're looking to propose some rules that will help address this, that some states weren't ready. Some states didn't take the actions they needed to set in place the structures they would need to have to be able to quickly re-enroll people who qualified, especially children. Some states chose not to take advantage of all the flexibilities we provided to them so they could make sure they're not inappropriately denying kids care. And so what we're going to do now is we learned a lot. Some states were really good about working with us, accepting our flexibilities. Some states just chose not to, and the result was many kids got kicked off.
Again, the state of Florida, boy, it's a tale of two cities. We do so well with ACA enrollment, but the state has disenrolled. They've gone through aggressive redetermination, and most people have been disenrolled largely because of procedural errors, red tape, and that's not right. What I'm hearing from neighbors back home, young people with complex medical conditions show up at the doctor, and they're not getting the care they need. It's costly. And I know that CBO recently analyzed the effects of 12 months continuous eligibility for kids on Medicaid. They found that 1 year of continuous coverage actually improves outcomes in life, meaning that when they become an adult, they're more productive, they earn more. That's going to help all of us. over time. So congratulations on making it through the day here with Energy and Commerce, but I look forward, we're going to draft some legislative language to help implement that, because we need to ensure in America that all kids get the care they need. Thank you very much, and I yield back.
Thank you. The gentlelady yields back, and that concludes all members who are present for questions, and I'll ask unanimous consent to insert in the record the documents included on the staff hearing documents list. I think I've given that to you. Without objection, I'll be in order. And I'm going to remind members they have 10 business days to submit questions for the record, and I ask the witnesses to respond. I ask the witness to respond to them promptly, and we would appreciate prompt response and appreciate your time, appreciate your effort, and appreciate you being here. And members should submit their questions by the close of business on May 1st. And without objection, the subcommittee is adjourned. Thank you. Thank you.